say that the setting may look very formal, but the meeting is not. So even if you are here to talk about a particular item, that doesn't mean you can't contribute as we have the discussion. And what we always do first of all is ask everybody to introduce themselves who's here. To do that, you'll need to press the big red button in front of you when it's your turn. Say who you are, your organisation, and then switch the red button off afterwards, because if not, it doesn't work for everybody. We're going to go this way today. So we're going to start with Phil, and then it normally works out that people work out when it's their turn to say hello. Thank you.
Hi everyone, I'm Phil Holmes. I'm the Director of Adults, Wellbeing and Culture in the Council.
And good morning, I'm Rachel Leslie. I'm the Acting Director of Public Health here at City of Doncaster Council.
Good morning, I'm Glynis Smith. I'm the Hatfield Ward Councillor and the Chair of Health and Adult Social Care Scrutiny.
Hi, I'm Laura Sherburn. I'm Chief Executive of Primary Care Doncaster, the GP Federation.
Good morning everyone, I'm Richard Parker. I'm Chief Executive of Doncaster and Bassett Law Teaching Hospitals.
Good morning, my name is Margaret Naylor. I'm Chair of the South Yorkshire Local Dental Network.
Good morning everyone, my name is Agatha Agema. I'm a Public Health Improvement Coordinator at the Council and the Oral Health Lead.
Good morning, I'm Sarah Robertson. I'm a consultant in dental public health working for NHS England, North Eastern Yorkshire.
Good morning, my name's Debbie Stovin. I am a Senior Dental Commissioner working across the 3 ICBs, but actually have a major focus on South Yorkshire ICB.
Morning, I'm Ailsa Layton. I'm the Director of Transformation for the South Yorkshire ICB based in Doncaster Place.
Morning everyone, I'm Anthony Fitzgerald. I'm Executive Place Director for NHS South Yorkshire.
Morning, Lee Galtz. I'm Assistant Director for Children's Services at the Council and I'm here for Rihanna Nelson.
Hello, my name is Toby. I'm the Chief Executive of Ardash. Nice to see you.
Morning everybody, I'm Chris Margrave, Director of Property Services and I'm here for Dave Richmond today.
Morning everyone, I'm Megan. I'm part of the Well Doncaster and Shaping Stainforth team.
Morning, I'm Lucy and I'm the Health and Wellbeing Apprentice for Shaping Stainforth.
Morning, I'm Rachel Rogers. I'm one of the Public Health Degree Apprentices at the Council.
Hi, my name's Romana. I'm one of the Public Health Degree Apprentices at the Council.
Morning everyone, I'm Hamna Saeed, a National Management Trainee in Public Health.
Morning everyone, Louise Robson, Public Health Lead here at the Council and I support the board. Thank you.
Morning, I'm Fayessa. I work in the Health Determinant Research Collaboration in Public Health here in the Council.
Hiya, Karis Williams, Public Health Coordinator in the Health Determinants Research Collaboration within Public Health. Thank you.
Morning, my name is Mario Staba. I am Community Link Worker for focus on Gypsy, Roma and Travelers.
Hi, I'm Franjo. I'm the Chief Operating Officer of Healthwatch.
Hi guys, I'm Whitley Marie Smith and I'm a Gypsy Roma Traveller Link worker also.
Morning, my name's Mandy Espy. I'm the Health Inequalities Lead across Doncaster Place.
Morning everyone, my name's Ruth Bruce and I'm the Doncaster Place Development Lead.
Hi everyone, I'm Councillor Sarah Smith. I'm Cabinet Member for Adult Social Care. Thank you.
Morning everyone, I'm Jonathan Goodwin from the Council's Governance team.
Thank you, and I know Karen and Grace, is it, Miss?
Morning everybody, I'm Karen Seaman, Public Health Improvement Coordinator, part of the Well Doncaster team, but I'm here today and I lead on Shaping Stainforth.
Hi, I'm Grace and I'm the Youth Worker Apprentice for Shaping Stainforth, which is within Well Doncaster.
Okay, lovely. It's great to see so many people. For people that haven't been before, we are the Health and Wellbeing Board and our role, I always say, is really simply to improve the health and wellbeing of all residents in Doncaster. So we have a packed agenda, as we always do. I will say to our speakers, if you have an allocated time, I will attempt to keep you to time without stifling the conversation and the questions. As I mentioned at the beginning, anybody is welcome to answer any questions, make any points, and then obviously I will sum up after every agenda item. But I would ask people to look at the agenda pack and think about the recommendations that the speakers are asking us to consider, so that when I come to it, everybody is happy to support those recommendations. What we often tend to do is add recommendations as well, so really welcome contributions about how we do that. Okay, I have to go on to the formal bit now, so the glasses have got to come on. So, apologies for today's meeting have been received from Dr. Rupert Suckling, Dr. Nabil El-Sindi, Dave Richmond, Lucy Robertshaw and Cynthia Ransom, but we have substitutes, so we have Rachel Leslie, Acting Director of Public Health, who's deputising for Rupert Suckling, Chris Margrave, Director of Property Services from St Ledger, who's deputising for Dave Richmond. Are there any other apologies that need to be noted, please?
Rihanna Nelson.
Rihanna Nelson. And we've got Lee deputising for Rihanna, so thank you.
And Rachel, there's Vanessa Powell-Hoyland, who should have been here, but she's sent apologies, I think.
We'll note those. Thanks very much, everybody. Can't see any more. So we are not expecting a fire practice today. If the alarm sounds, please leave the building by way of the fire exit through the doors at the rear of the chamber. When you have left the chamber, proceed down the stairway and exit through the emergency exit on the ground floor. If there is anybody with mobility issues, please wait in the refuge area at the top of the stairs where the emergency evacuation lift is located, and use the intercom situated to the left-hand side of the lift doors to call for assistance. The designated assembly point is in the public square in front of CAST beyond the fountain. I would like to inform any members of the public and press that today's meeting will be audio-visually recorded. By entering the council chamber, you accept that you will be recorded and your images retained and broadcast by the council on its website and on YouTube. If anyone intends to record or film any part of today's meeting, please ensure that this does not disturb the conduct of the meeting and you only focus on recording those people participating. On to item 2, Chair's announcements. I've already made those at the beginning in welcoming people. We've just been joined by Councillor Nigel Ball. Do you just want to press your button and just say who you are?
Hello everybody, I'm Councillor Nigel Ball. Sorry I'm late. I'm Cabinet Member for Public Health, Leisure, Culture, Communities. Thank you.
Thanks, Nigel. Item 3, there are no items on today's agenda where the press and public are to be excluded. So we'll move on to item 4. Public questions. This is a standing item on our agenda aimed at providing an opportunity for the members of the public to ask a question or make a statement. Please note that questions or statements should relate to an item of business on the agenda for today's meeting. Are there any elected members or members of the public that would like to ask a question? Oh, just got one. Anybody else? Just one from Glynnis. Councillor Smith, thank you.
Right. I really wanted to explain today something that happened to us as a family earlier in the year with a family member and the difficulties that we faced around this. So my daughter's partner in April this year became quite poorly with severe and enduring headaches and light sensitivity. It became so bad on 2 occasions that he attended A&E on the 11th and the 14th of April. On the 11th, he had a CT head and attended on the 14th and was sent home both times with pain relief. The headaches continued and actually got worse. He was losing weight and looked terrible and was literally sitting in a dark room wearing sunglasses. This is a 36-year-old roofer previously fit, attended the gym 3 times a week, played golf and tennis. So I knew we needed to do something. I asked him to make a GP appointment. He'd been seen by several different GPs at the practice who'd all prescribed pain relief. So I asked him to make another appointment and I went with him. And anybody who knows me here, I did the talking. So I explained the signs and symptoms and that, you know, in my view, we needed to see a neurologist with some speed and that a scan with some contrast would probably be beneficial. The GP agreed and did an urgent referral to neurology. I would add that I actually left my pen, and the GP phoned Adam and said, your mother-in-law has left a pen. I think he was hoping I didn't go back to pick it up. So we got the very urgent referral to the neurologist who I'd worked alongside for many years, and I explained the symptoms. What he asked for was an MRI with contrast urgently, and also because hormone levels were very skewed, a referral to endocrinology. Those things happened very quickly, but at this point I would say that we were sent for further bloods, and we were able, as we are still, I believe, up until the end of this month, to go to the drive-through service at the Keep Moat. At that point, Adam was unsteady on his feet. Had we had to get him either to our acute hospital or our GP practice, that wouldn't have been easy. But it was very easy, and we were able to do it very quickly. The bloods did show that his hormone levels were all over the place, and he had the urgent MRI with contrast, which actually showed a benign growth on his pituitary gland, which had been bleeding and obviously caused the pressure on the optic nerve. But at that point, it wasn't causing pressure on the optic nerve. So the treatment for future is, you know, keep an eye on it, to have regular looks at it, and he's actually fitting well. And there is some good news to add. He's no longer a roofer, and he's training to be a surveyor with Sheffield University. This isn't about complaining about the NHS, the organisation I worked for the whole of my adult life. I used to tell people during training that if you snapped me in half, you'd find NHS down the middle. And I appreciate the pressures on A&E, absolutely, that there is no doubt about that. But Adam was actually made to feel like a nuisance, like he was pulling somebody's leg and like there wasn't anything wrong with him, and sent home with some pain relief. And I just wonder, for people who aren't necessarily that good at articulating the needs, how we look after those who are much more vulnerable than ourselves. And I think it's important that no matter how difficult things get, that we don't lose our compassion and sight of why we went into the job in the first place. So that's my story. I think it needed to be said, and I'm pleased that I was able to say thank you to this meeting.
Thank you very much, Glynis. Would any colleagues like to comment?
mean, I presume it was our A&Es, was it, Glynis? I think I would agree with you that irrespective of the pressures, the primary role of the NHS and our colleagues is to treat people with care and compassion. That's what they're there for, that's what they're trained to do, and that's what we should aim to do at all times. And that does include listening to people and trying to understand what the issues are and make the appropriate diagnosis or referrals. And it sounds complex, and if we haven't looked into it and you'd like us to look into it, then we'd be more than happy to do so. Because sometimes it is, as you would know from your career, difficult to get to a diagnosis, particularly if you're working through a series of steps. And the first steps that A&E would go to would not be referral to a neurologist at that stage unless something's identified clinically. And in most cases, the first course treatment for patients presenting with headaches, as you know, would be CT rather than contrast or contrast MRI, because those are normally tests that are requested in the community rather than from us. But that doesn't detract from your story. Your story is one of having to push for and having to go and support to get to the end point in terms of a diagnosis. And it's also about access to services in a timely manner so that you know, people can feel confident about that. You are absolutely right. There are some challenges at the moment with the services, with the demand, with the workforce issues. But what I would say is that we are trying to work through them and maintain those primary reasons for the NHS to exist. And like yourself, I'm in my 42nd year in the NHS. I trained as a nurse. Which was all about care, compassion and providing that support to patients. I haven't lost any of that. That still remains the drive, that still remains the commitment, and that still remains the effort every day to try to make sure that happens in every case. But I am conscious that sometimes we don't get that right, but that doesn't mean we don't redouble our efforts to do so. And experiencing stories is always a way of refocusing people's attention. It's pretty clear that, you know, A&E this winter is going to be really difficult, and therefore we absolutely have to, you know, do that as a trust, but do that as well with partners to try to make sure that the number of times things like this happen are absolutely minimal, and when they do, we've learned some lessons from it. And so, you know, thank you very much for raising it. If you do want us to look into any specific aspects, then just let us know and we'll provide a full response to, you know, the detail of people's decision making and any care or compassion issues similarly.
Echo Richard's point, and thanks, Glynis, for demonstrating that story here. Glynis brought reference to the phlebotomy service at the Power Stadium, which will be closing on the 24th of November of this month, and we've had some separate correspondence outside of this meeting on that. We recognise, as I'm sure all members of the public recognise around the Health and Wellbeing Board, that we are having to look at prioritisation of services. We received a letter from NHS England yesterday that told us very much to prioritise our work for the rest of the year within the budgets that we've got, particularly focusing on urgent and emergency care pathways. However, for Adam and for people like Adam who were suffering from accessibility or mobility issues, it's on all of our services to make sure that we take account of that when accessing services, and that in the case of phlebotomy, we need to make sure that that's appropriate both at the DRI site and Mexborough Montague site, but also at our 37 general practices where phlebotomy services are provided. So certainly I'll take that back and make sure that that assurance is there.
Richard?
One of the things I would say, just in addition to Anthony's comments, is that I personally think it's really clear at the moment that the pressure on the NHS has manifested itself partly as a result of some of the challenges from COVID, of which the drive-through was a solution at a point in time, and it was the right solution at a point in time, but that point in time is not static, it changes. And therefore, the change process in terms of our key questions and what we need to do as actions is quite complex. One of the things I do think we're going to have to do, and it is in a conversation with people like the ones in attendance here, but the wider community, is to begin to explore and think about the way that services will have to change in the next very short period of time if we are to maintain and build and provide the sorts of services people want. Because we shouldn't underestimate the workforce challenge as one of the drivers for the change that we need, because invariably, if we provide services in multiple sites, then those services require more staff, and in some areas those staff aren't available. And I have an invitation to the Review and Scrutiny Committee, and one of the issues on the agenda there will be oncology. And oncology is one of those services facing huge pressures nationally, and the model that people have got used to will change. And I've been here before when we've talked about the GP service model, where people have an expectation of historically how general practice runs, and the expectation is that at the moment will run as now. And unfortunately, for lots of reasons, if we don't change those services, then some of the concerns patients have will be more acute. So I think the next phase is with partners like Anthony and with Toby and others, is to look at what people really need from the services and how we can improve them. But with that realisation is that the model will not necessarily be the same, because it can't be, it has to change, because if we don't change, then actually things like waiting times get longer. And so I do think soon we're going to have to start that sort of reasonably sensible conversation about the aim for us is high quality care provided in accessible places that meet the greater good of the communities. And that will mean that we will look at moving things out of hospital to the community. I think we're committed to that. We're looking at it now because that is a lot more flexible and easy for patients. And in reality, it's a lot more cost effective than the DRI solution. And I think that will, in the next phase, include things like phlebotomy. But at the moment, at this point in time, the options that we have are the ones that we're practically working through that we think meet demand now. But I do think this next year is going to be a conversation, has to be a conversation about we can't provide everything everywhere anymore. But what we have to do is provide really high quality things in the most accessible spaces and places for the vast majority of the people we serve. So it's just, a forewarning really of some of the harder conversations that we will need to have.
Okay, thank you. I'll finish it there. I think those conversations, it would be useful to bring that back to the January Health and Wellbeing Board meeting to start those conversations, because I think we're all aware of the need to change because of the lack of investment and the lack of funding, and obviously workforce challenges as well, which you've explained. So I think it would be good to have that discussion. Thinking on the agenda, we've got the Fairness and Wellbeing Commission outcomes. If we're talking about equity and fairness, then that's something that has got to be at the heart of the Health and Wellbeing Board's work. So looking to Louise to see if we could perhaps have an agenda item for January to bring that discussion. Just wanted to pick up on something else. I'll bring you in a second, Richard, that Glynis said. So Adam had the benefit of a mother-in-law that knew the NHS and knew how to get things done. And you made a really good point in terms of if people are vulnerable, how do we support those most vulnerable who don't have that support? So I wonder if there's some more work that can be done, looking to Fran now in terms of Health Watch, in making sure that people are everybody is aware of those patient support that's out there, the advocacy that's available in Doncaster, because certainly as a councillor, people come to me about the NHS because they're not sure where to go. And I don't know if that's something that we could look at, publicising, promoting more. I know we've all got a desire to use social media, but it would be great to see it in some of our community magazines that go out there, magazines that people probably keep. And it might be something that I know we've got a joint comms group, haven't we, that work across the NHS and the council. And it would be really useful to promote those services in there because I don't think most people know. And as you say, for the most vulnerable, they do need that support and advocacy. I'll bring Richard back in and then we're going to move on to the next item.
Yeah, it was just a little addendum really in terms of your points, Rachel, because one of the things that we're cited on, reminded on, is that one of the developments for the community diagnostic centres that took place at Barnsley took a lot of those services to what was called the Glassworks, which is actually a shopping centre. And what I think the early information that's come out of that is that by making that a centre that was where people went for other reasons, actually what they've seen is a reduction in the inequality of access to the service because people have got to go for different purposes. And they saw a 50%, as I understand it, reduction in DNAs, so people not attending appointments reduced by 50%. And the number of their population from particularly deprived areas who access screening went up by, as I understand it, 30% from their baseline figures. Obviously, that's still got to be maintained. But to me, there is something in that about what we're trying to do and how we do it, because actually, if that's just the result of making it more accessible, then it's a really fantastic result, and it's provided in an area that isn't as clinical and otherwise, that's got access to things like public transport because it's in the depot, and it's got access to much better car parking and other facilities. And people who are escorting them, as I understand it, are going with the patients and then taking the time that the patient's in the treatment or in the clinic and wandering around the shops. So I think they've also seen an increase in expenditure in their shops as a result of that, which is obviously beneficial to them. So to me, that's a multi-agency solution that's ticking lots of boxes that actually are about the local community and its well-being from other aspects, employment, income, as well as dealing with some of the health issues. So we are committed to looking at that, and we've got a piece of work underway that's doing that already, but we're looking at what estate we currently have within the NHS before we spend more money on additional estate and make sure it's in the right place. So I think there are some solutions where we can probably get to that sweet spot of benefit alongside of access that makes people feel as if the service is right for purpose. What I would say is, in terms of the second question, and Healthwatch may want to come in, is that the issue, I think, is that as Sylvia was speaking, the clinical staff in the audience will get into the same answer because the story was becoming a bit clearer in terms of what the clinical history was, the presentation, and what the next steps were, because people presenting with similar symptoms would be potentially considered to have got a migraine or something less significant. And so it's about when patients have been to services and seen services that we don't lose the opportunity, and they don't lose the opportunity to follow up or feel like they're being ignored or the story's not being heard or people aren't caring and compassionate. And it's that bit where what you don't want is people to think, well, I've been and they've given me an answer and there's nothing wrong with me, and then wait such a long time to reappear in services that actually the condition is significantly worse. And so I think we've got to think about how you address that for patients who've not got advocates who are, well capable and understand the issues and speak up in that way.
Definitely. So if we could look into Fran to see if that's something that you're happy to look at, that would be really... You don't have to come back in now, Fran, it's fine. It's just, if Louise... Rachel.
I'm sorry, Chair, because I know you want to move on, but I don't want to miss the chance to look at... I think we've talked about two things. I think we've talked about access, but we've also talked about experience, and they're linked, but I think will need to be addressed both together and separately. So the experience part has been about how somebody was treated, and probably a number of us have got experiences in the room of when we've advocated for ourselves and our families in a health environment because we know some of the words, or we know some of the language, or we know some of the processes. That shouldn't affect the experience that a person has with the treatment they receive or the opportunities for them. And access is another part of that as well, and we'll hear about that in our dentistry item, and we'll hear about access and experience in our item with our Gypsy Roma Traveller presenters later as well. So I think the tasks are right, it's just looking at them in two different ways. So one is around access, so knowing that things are available, knowing how to access that advocacy, and then the other part is the experience of people using and accessing those services as the next part.
Okay, thank you, Rachel. And can we pick up those actions? Is that... Yeah, we can pick up those ready for the next meeting. Okay. Thank you, Glynis, for raising that. As you can see, it's obviously... you've had answers. There's an opportunity there to have that conversation again with Richard. But I think, as always, is what happens at this board is that people bring their lived experience, which is so important, and then hopefully will lead to a better service, better support for everybody. Okay, thank you. Right, we are going to move on now to item 5, declaration of interests. Does anyone have any disclosable pecuniary interest or other interest to declare in relation to the business on today's agenda? If so, please declare it now and complete a declaration form from the governance officer, Jonathan. Can't see anybody indicating. Lovely. Okay, item 6, minutes of the Health and Wellbeing Board that was held on the 31st of August. The minutes of the board's last meeting are attached at page 1 of the agenda papers. The board is asked to consider and approve these as a correct record. Can we agree the minutes as a true and accurate record? Agreed, thank you. Okay, on to our presentations. So our first one is item 7, which is the update on oral health improvements and dental services. I'm really pleased that we have, I'll call you the dental team here, to update us, because we have been talking about this for some time at the Health and Wellbeing Board, so really pleased that you can come. I will leave it to you to decide. I don't know if Anthony's introducing, and we've got about 35 minutes for this item. No doubt you will get a lot of questions.
Thanks, Chair. Not much from me because, as you say, we've brought the experts with us today, and I'll let them introduce themselves in turn. Members will remember that NHS South Yorkshire assumed responsibility for commissioning of dental services across South Yorkshire in April of this year. And oral health and access to dental services is a significant concern for our residents and the people that we serve. It's a consistent theme in insight and engagement work that we have, and has a significant impact on health and well-being. Improving dental services and oral health is a priority for our partnership, and today we're going to present on the current state of oral health and in Doncaster, and we'll be painting the picture of that. We'll also give a flavour of some of the improvement work that we're doing within the national frameworks and the abilities that we have to give, and some of our key priorities going forward. So I'm going to let the team introduce themselves, and they have there's a lot of information in the pack, I realise, but this presentation will summarise most of that.
Okay, morning. I did introduce myself earlier, so I'm Debbie Stovin. I'm Senior Dental Commissioning Manager across Yorkshire and Humberside, covering the 3 ICBs, but I'm predominantly now working with South Yorkshire ICB in terms of commissioning of dental services. We're going to split the presentation across 3 of us. So we're actually going to capture myself, Sarah as a consultant in public health, and Agatha from the local authority in terms of the oral health prevention side as well. So we have prepared the report jointly, so you've got an overview from both sides, because each organisation has different responsibilities. So the ICB is now responsible for commissioning of dental services, where the local authority is obviously responsible then in terms of the oral health prevention. So you'll hear both sides of that, and I hope the packs give you quite a lot of information. I do apologise, it is quite a lengthy report and appendices, but hopefully that gives you much more detail that you've been able to read. So we are going to just sort of cover some key points, I think. The first thing I just wanted to put out there is just, and I'm not going to dwell on these points, but these are just sort of public perceptions, just to sort of put that out really. So people do talk about being registered at a dentist. Nobody's registered at a dentist. That's not been in place for many years. But it's unlike you are with the GP. Obviously, you do register with the GP, but dental is different. Dentists are responsible for delivering a course of treatment for a patient, and that is it. But they do, for those of you that do attend a dentist regularly, will have regular lists of patients that they will see on a regular basis, recall when they need to be recalled, and provide ongoing treatment. But the registered bit is a bit of a myth now. Patient records as well are not transferred like you would with the GP. For changed GPs, you transfer your records, automatic transfer. In dental, that isn't the same. Your patient records with the dentist are responsible of that dentist at that time, unless you actually ask for that to happen, if you do end up changing a dental practices. Dental services being free at point of delivery, they are subsidised. So those of you that are fee paying and responsible for fee paying, there is a pay that goes towards your cost of treatment, and that is determined on what you pay in terms of what level of treatment, what level of cost you actually pay, whether it's a check-up, whether it's treatments for such as things of extractions, fill-ins, etc. So it raises up in terms of bands. Practices accepting new patients for regular dental care. There is a site, www.nhs.uk. It's a digital platform where all the dental practices have their details on there. It has been the responsible for the practices to actually keep that record up to date. That is not our responsibility to do that. It is the practices. And until recently, that wasn't mandated in their dental contracts. It was their responsibility to do it, but we had no contractual powers or levers to make them do that. That is changed now. So they are responsible for keeping that mandated, and that is part of their dental contracts now in the NHS. It doesn't mean to say that if it's on there that they will necessarily be accepting regular patients and they've got places for that, but their details on that site should be up to date, and we're able to monitor that now, and that's something we've recently been able to start to do as part of the contract dental reforms. But again, it is for the practices to manage their own waiting lists. We have no influence on that. And private dental practices, many practices provide both. They provide NHS and they provide private. And as they are independent contractors, and they're at liberty to do that. So just to talk about some challenges, and some of these are probably not going to be a surprise, really. But the access and inequalities. We have inherited contracts that have been going back many years. So back when we had primary care trusts, and those contracts were inherited to us, and that was to NHS England, and then more recently to ICBs from April of this year. There's inconsistency in those, there's inequity in those. They've been around many years. The contract is back to 2006, and so we have got that inequity across Doncaster, across South Yorkshire, across nationally. They are very complex contracts, and we've got some inconsistent pathways. Practices have now got waiting lists. Many of them have got long waiting lists for people to be able to access for regular care. That's for regular care. Mentioned earlier in an earlier discussion about COVID and the effect of the pandemic, that has added to the backlog in dental practices. And it's obviously compounded then the existing challenges we already had in terms of access to dentistry. When COVID first hit, dental practices were shut for 3 months. They were not able to open. They did triage over the telephone, and then it's been a gradual increase for them to be able to be open and seeing patients. And that was because of the infection prevention control guidelines that was issued nationally. We are back to obviously being fully open, and contractually they are contracted to be meeting their full targets now. Dental workforce, just like a lot of other areas in the NHS, is difficult. The availability of clinical workforce in practices is difficult. They experience recruitment issues, retention issues, not just dentists, but actually the wider clinical team, so your dental nurses, your hygienists, etc., and the impacts of funding on that. The limitations I touched on a minute ago regarding the 2006 NHS contract and the progress of that as the National Dental Reform Programme. It is happening. We got the first phase of that last summer, but it's very slow, and there's still a lot more to do in terms of being able to do anything with the contract. That leads me on to the national contract. So as I say, 2006, a lot of our providers, a lot of our dental practices have got contracts in perpetuity. So we're very limited to what we can do with that. They are the contract offers us little flexibility to do it. It's very difficult for either us to do anything differently or the provider. But we have got some opportunities coming, which I will talk about in a second. They are contracted based on activity. We talk about units of dental activity, which varies depending on the level of treatment you're getting. So the lower units of activity for your treatment, for your routine stuff, so going for your checkups, and they'll get more activity for the more complex treatment. The tariff is variable across practices. In Doncaster, fortunately, there was some work done several years ago, where they're pretty much paid on the same UDA rate, which is totally different to a lot of other areas in South Yorkshire. So I'm not quite sure what the history of that is. I've been trying to find out. But we are pretty much paid on the same level, which is a benefit for us actually in Doncaster, but it does cause issues elsewhere. They are contracted to deliver a set number of units of dental activity, so they've got set total contract values, and that's what we have to work within. There's no extra money to increase that unless we get people handing contracts back or some of their units of dental activity back. We've had no contract handbacks in Doncaster for some time. Contractual and new day handbacks is what I've just been touching on really. It does help us be able to offer activity out if other provider does that, but we often get those handbacks if there's been recruitment or retention issues and they're really struggling to be able to deliver. And we are seeing that across South Yorkshire, but not necessarily in Doncaster. But they are very restrictive in terms of the contract. I talked about not really having handbacks. We've had two practices where we've actually talked about rebasing since April 21. So they've literally handed us some of their units back. So they've reduced their contract slightly. And as you can see on there, it's very slightly. And that 2,820 UDAs, to put into context, equates to less than 50% of what we'd class as a dental chair. So in a surgery, you'll have several rooms with a dental chair. We expect a full-time dentist with in a chair would probably provide in sort of 6,000 to 7,000 UDAs in a year. So we've only had that many handed back to us in the last couple of years, which is really positive in Doncaster. And we've been able to reallocate those around to other practices. So we've not lost the activity in Doncaster, we've reallocated it, so we've not lost it. Other areas have got very, very different positions. We're having big contracts handed back to us because they're struggling. And we are currently above we've got a Yorkshire and Humber average for the UDA, units of dental activity, which we are currently reviewing with the ICBs anyway. But actually all our Doncaster providers are above that, so that it's more beneficial to them because they are actually above that, which is probably why we've not been receiving the same levels of handback and difficulties in Doncaster that we have seen in lots of other areas. I want to hand you to Sarah.
Thank you. So I'm just going to take you through some of the data now around dental access, because I know it's something that everybody is very interested in. So this table shows some of the access levels. So those who've seen an NHS dentist in the different local authority areas across South Yorkshire and for England. Sorry, the numbers are quite small, but I'll try and take you through it as best as I can. So pre-pandemic, just over 66% of Doncaster's adults saw an NHS dentist in the preceding 24 months, up to the 31st of December 2019. And 66% of children saw an NHS dentist in the preceding 12 months, up to the 31st of December 2019. And this was similar to the neighbouring local authorities across South Yorkshire, but yet it was higher than England's levels. We have to remember, though, in addition to those figures, some people actively choose to access private dental care as well, but we don't actually have any data available on the numbers or percentage of people accessing private dental care. So this is purely NHS dental care. But then, of course, we had COVID. So we had several months of practice closures due to COVID, followed by months of limited patient access or patient throughput due to heightened infection prevention and control requirements, because, of course, dentistry is an aerosol generating procedure, so it was very risky, a risky thing to be practicing during COVID. And this had a significant impact on access to dental services. So on the slide, if it was a little bit bigger, you'd be able to see that the access levels dropped significantly right across South Yorkshire and England throughout 2020, 2021. Due to the backlog of care, demand for NHS dental care is now significantly higher than pre-pandemic levels at all practices. And while the number of available appointments for regular and routine treatment is increasing and access figures are gradually improving, dental practices continue to balance the challenge of clearing any backlog with managing new patient demand.
And in addition to that, dental teams are facing significant workforce challenges. Staff are continuing to leave the NHS, and that also hinders opportunities to increase appointment levels as well. So the latest access figures provide data on access up to June 2023, and that's on the far right of the table. So please note that the figures for up to June 2023 do differ from those which were printed in your packs that you will have received. And this is due to NHS Digital recently finding errors in the data mapping to local authorities. So they have just republished the new figures. So the slide shows the new figures. Whilst restoration of NHS dental activity continues, it is encouraging that the latest figures for access indicate that access levels in Doncaster amongst adults are returning to pre-pandemic levels, with over 63% of adults having accessed a dentist in the last 24 months up to June 2023. And over 60% of children have accessed a dentist in the previous 12 months. You can see quite clearly that there is significantly better access in Doncaster than in England overall, as the figures for England are only around 41% for adults and 53% for children.
So it's back to me. Okay, so we're looking now at some initiatives to strengthen and improve access to dentistry. And we've got some levels of flexibility in the contract, which we're already using to some degree. But moving to the ICBs is allowing us to actually be a bit more innovative and re-look at what we're actually doing, looking at different approaches, looking at other evidence-based prevention, looking at quality, looking at skill mix within the practice. We know we've got the challenges, but we're still, there's things that we are looking we can try and do to obviously meet the needs of the population. We've done, with public health colleagues, undertook an oral health needs assessment. We've produced South Yorkshire-based profiles and actually place-based profiles, which were also in your packs. These actually identify some priority areas to support investment and meet the needs and the deprivation in the different areas. They were done in 2022. And that's given us a baseline then that can help inform our commissioning intentions going forward. We do have a flexible commissioning scheme already running, and we were the first region as Yorkshire and Humber with NHSE to actually undertake this approach in the country. And we are very proud of this scheme. We have reviewed it and it has come out very positively, and it's been extended to the end of this current year at the minute. So we extended it over the transition period moving to ICBs. In Doncaster, we've got 13 practices that are involved in flexible commissioning, and that targets around prevention for specific groups, targets access to care, utilising the skill mix and twisting part of contracts, which it does allow us to do in the contract, but we've only got a twist of up to 10%. So 10% of their activity is released to provide us the skill mix within the practice to do things slightly differently. But what we want to do is actually look and expand on that. And we're currently doing another review led by one of our clinicians, one of our other LDN chairs, so the equivalent of Margaret in Humber North Yorkshire has taken a lead on this. And each of the ICBs received reports from us in the summer when we were first coming over to the ICBs to look at what the ambitions could be and what we can actually do, and looking at the scope of innovation. And there is an ambition across the three ICBs, and South Yorkshire supporting the fact that we need to be looking to twist more than the 10% to try and innovate services with the practices support, trying to move away from the unit of dental activity focus of the contract, which is very, very restrictive. It's not an attractive thing, and the practices are all wanting to move away from that with support of their local dental committees. So we're looking at what we can do with that and what's feasible within the regime and the regulations of the dental contract. We're looking at targets of high need. We'll be able to look much more deeper, working with our place teams within South Yorkshire and trying to look where we can fit things differently. We're going to review the entry criteria for practices. At the minute, they have to be really, really well-performing practice and meeting at least 96% of contracts to be able to flex contracts. Because what we don't want to do is flex contracts in practices who are not really performing at the minute. But what we want to do is re-look at that and actually say, well, actually, if you're not performing, you're not meeting activity, what are the needs in that population and what can we do differently so you can actually meet the needs of that population? And looking at what measures we can do for that and looking at what the outcomes can be and moving away from the focus on units of dental activity. And looking at, like I say, the opportunity to target and approach the harder reach groups, engaging with patients, looking at practice lists, what we can actually do to reduce those and address the waiting lists. So there's lots of scope for us to do something differently, and that's what we're trying to do and start to do now. We have got some pilots going on across the region. We've learned from a pilot in Leeds on homelessness, and that's been successful. That's had an evaluation which has been successful. In South Yorkshire, we are looking at extending that, and we've already started in Sheffield, and we've now identified a practice that we can do this with as well. Working from the Flying Scotsman is a central location service. It's ideal. We've done some work, well, Sarah has done some work linking in with the agencies across Doncaster, working with the homeless population, and we're working with the practice to be able to have a session so that they can work together to meet the needs of the homelessness. And we'll be working with that and looking at and evaluating that as well. So we've got 2 across South Yorkshire that we've just started recently. We are working also collaboratively across South Yorkshire with the South Yorkshire and Bassett Law Acute Federation Paediatric Innovator Programme for dental, looking at transforming pathways and care pathways for the children to improve access for paediatric dental services, which is a big issue in Doncaster.
So we know that access to dental care is really, really important, but we also know that prevention is just as important. We know that oral diseases like tooth decay, gum disease, and oral cancer are largely preventable, and that having good oral health is essential for good general health and well-being. Oral diseases share many common risk factors with other health problems. Having poor oral health can affect diabetes control. It's also been linked to coronary heart disease, stroke, obesity, and aspiration pneumonia. The Yorkshire and Humber Oral Health Needs Assessment demonstrated that poor oral health disproportionately affects the most vulnerable and socially disadvantaged individuals and groups in society. So that includes individuals and communities that are more deprived and vulnerable children known to the social care system, people with severe physical and or learning disabilities, poor mental health, or those who are overweight or obese, older adults, those affected by substance misuse, prison leavers, the homeless, Gypsy, Roma and traveller communities such as the Roma community in Hexthorpe, asylum seekers, refugees and migrants. Doncaster residents experience some of the highest levels of tooth decay. By the age of 5, a third of children in Doncaster had tooth decay in 2022, with each of those children having around 4 teeth affected. Although there has been improvement in the last few years, Doncaster still has higher levels of tooth decay than other South Yorkshire local authority areas, Yorkshire and the Humber and England. Around 30% of children surveyed in 2022 had active untreated decay, with 3% experiencing advanced decay indicative of severe pain and infection. Many of these children may have experienced sleepless nights, difficulties with eating. It can affect their learning. They may need time off school and obviously time off work for parents and carers too. As tooth decay is a progressive disease, tooth decay in children is a good predictor of tooth decay in adults too. It can affect communication and confidence, nutrition, especially in older people, and overall quality of life. Many children end up having to have multiple decayed teeth extracted under general anaesthetic, which is an unpleasant experience for the families involved and not without risk. Almost 9 out of 10 hospital tooth extractions amongst children aged 0 to 5 years are due to preventable tooth decay. And tooth extraction is still the most common hospital procedure amongst 6 to 10-year-olds. Doncaster, along with the other South Yorkshire local authority areas, consistently experiences some of the highest levels of hospital tooth extractions seen nationally. The cost to the NHS of hospital admissions for tooth extractions in children aged 0 to 19 years in England during 2021 to 22 was over £50 million. But each incident will also incur indirect costs. Things like time away from school and time off work for parents and carers looking after the children. As such, it is essential that we place enough focus and resource on prevention throughout the whole life course. One-to-one preventive advice and interventions for patients, such as fluoride varnish application, will happen during dental visits, as set out in the National Toolkit for Prevention, which is called Delivering Better Oral Health. However, community oral health improvement activities, which work at a more whole population approach or a targeted population level, are also commissioned by Doncaster Council, and Agatha's just going to take you through some of these that are happening in Doncaster.
Thank you, Sarah. So currently as a council, we're delivering the recommendations that arose out of the needs assessment, which was carried out in 2018 through the Oral Health Advisory Group Action Plan. The specifics include a supervised toothbrushing club. So this is in early years settings in primary schools where we provide toothbrushing supplies, including toothpaste and toothbrushes for children to have at least one toothbrushing session during the school day, every day, under supervision. We recognize that for some of these kids, this is the only time they get to brush their teeth, so it's really important that we encourage settings to sign up and we continue to run these programs. We also provide oral health packs through the health visiting scheme. We provide fluoride toothpaste and toothbrushes at the 6 to 8 week visit, as well as a tummy TP free flow cup, because we realize that one of the contributors to this problem is prolonged bottle feeding and pacifier use. So the cup is to encourage that transition at the right time and prevent prolonged bottle feeding. We also do provide oral health packs at the 2 to 2.5 year contact by the health visitors, as well as the oral health leaflets to encourage parents to make the right decisions regarding the foods and drinks that their kids consume. We offer in-house oral health training programs to staff and service providers who are not dental professionals, also in schools during our supervised toothbrushing clubs, as well as other training programs and other training programs just to encourage, to educate both staff and the general public regarding oral health. We're reintroducing a free drinking water scheme that allows families to refill their water bottles and hopefully encourage them to make healthy choices regarding what they drink. This is in businesses around Doncaster, and we're also running the Kind to Teeth campaign just to emphasize that message that milk and water is the only healthy choice for kids to protect their teeth. We have links with the flexible commissioning practices through the Making Every Contact Count to also signpost users to help with addiction management, such as stopping smoking and alcohol use, as well as weight management program, as well as water fluoridation program, which offers good returns for investments with regards to protecting oral health. Thank you.
The final slide we've got in terms of what needs. Sorry. Okay, so just a final slide, and then obviously I'm sure you've got lots of questions. What needs to happen? Working together. We can't do this alone. We need to work very closely with all our stakeholders. In South Yorkshire, we've pulled together a South Yorkshire dental event on the 30th of November. Health and Wellbeing Board members, along with Overview and Scrutiny Committee members, members from the ICB, dental practices, lots of other agencies, Healthwatch, for example. We are pulling together an event 30th of November, and it's happening in the morning. It's happening in Rotherham, so you should have received you should be receiving details if you haven't already. Dental system reforms. These are national dental system reforms. So the national team are leading on this. We have had the first stage, as I mentioned earlier, back in the summer of last year. There are more being worked on, and hopefully they will help continue to do some of the changes we need in terms of the dental contract. Commitment to further engagement. We do need a commitment to further engagement, and we are continuing to engage and working with local authority colleagues, etc. Continued development of the Oral Health Improvement Programme. With support, the All Health Improvement to be part of the health and wellbeing strategy. It's not currently part of your strategy, and we need that to be part of that. And continued support for water fluoridation.
Okay, thank you very much. Very comprehensive. I am going to look for questions. I'm going to basically take one round of questions due to the time. So Toby's hand was up first.
Hi, thanks very much for that. Hugely comprehensive, as is the 140 pages. The thing that I've not seen yet, and I wonder if you could comment on, is what in 18 months' time would constitute meaningful success. I don't doubt the effort and the energy and the many programmes, but I guess I'm looking to work backwards, because I don't regard 1/3 of people not having access as comparatively good. I regard it as an inequalities issue. So help me with what is success. And maybe within that, as we sit here at the moment, within 8 miles of the council chamber, there are 10 dentists that will register people. There are, I think, 32 that won't. What would you expect that number to be in 18 months' time? I completely get that access, as you were saying, Agatha, isn't the only thing. But if only 10 will currently register in Doncaster, what would you expect that to be in 18 months' time? Thanks a lot.
So I think the first thing to say about access is we've never had 100% access to dental care. So I think what I was trying to say is we're moving towards what we had pre-pandemic, which actually was pretty good, to be fair, in Doncaster, around 66%. When you look at kind of the national levels are a lot lower. There are always patients that will choose not to have NHS dental care. So that's one reason why we'd never get to 100%. But there's also a finite capacity of NHS dentists to provide that care, and there's only a certain number of units of dental activity in the system. So I think, as Debbie was trying to explain earlier, we can really redistribute units of dental activity. There isn't additional monies to procure new dental practices at this time. So we would hope that the access levels would continue to increase. I would hope, the next time we get the figures, we would see that they were, right back to pre-pandemic levels. But I don't think we would ever get a lot higher, to be fair. I don't know if Margaret wants to add to that.
Well, just to go back, there is no such thing as registration. So you can't register with a dentist. You may ask a dentist if he can provide a course of treatment, and as you said, there are 10 practices providing a course of treatment. However, if you were in pain, there are things in place so that some of the practices would take you on to see you in pain, get you out of pain, and then maybe put you on a waiting list. Were you offered, it sounds as though you've sort of worked through the dental practices, were you offered to be put on a waiting list? Because most practices have waiting lists now.
Toby, do you want to come back?
Well, in answer to the question you just asked me, I haven't sought to get a dentist in Doncaster. I just did what the presentation advised and went through the website while I was listening to you. I understand that 100% isn't desirable. I still think out of the event at the end of November, it would be good to set a sort of forward trajectory of where we're trying to get to as a health system. Otherwise, it's just effort in a broken sort of system in terms of national dental health, isn't it? We surely want to get to a better position if we, and I'll finish in a sec, Chair, but the point that's being made is we can't spend more than X. Is that really true? Couldn't, as an ICB, we decide to divert resources from mental health in Ardash into dentistry if we wanted to. So it isn't the case that there's a sort of ring-fenced cap on dental expenditure, is it? Thanks.
Thank you.
Yeah, thanks. I think Toby's question was, what does success look like in the next 18 months? So I'll give my take on that. I think, as has been described in the presentation, there isn't a national target and standard as such. And I think actually we can debate what we can around standards and targets, but I actually think dental suffered as a result of that. It hasn't been on the highest priority of some of our in things like our elective weights, etc. What would success look like? I would like to see a much better conversation and engagement with the public, so that we don't, so it is more obvious to our public about how they can access dental services. Some of the additional schemes that we might be running, and what we see as a result of that is a reduction in the amount of complaints or confusion that we have around our public, and we have to think long and hard about how we measure that. So that would be an increase in success for me. Toby's right. We are on one hand hindered by the contractual arrangements, and I think that's been well articulated. But as an ICB, if we decide that dental is really our priority in South Yorkshire, then we can reallocate resource. The issue, of course, is the same as what's been described previously in the item about what is our priority and how we work within the resources that we can. But I am keen, particularly, to look at adapting our system and working together so that our public who find it hard to access dental services, that it is more obvious for them about how they can.
Right, I've just got other questions. So in order, there was Karen, Nigel, and then Sarah. Is that okay, or did you want to come back, Sarah?
I just wanted to just come in a little bit on it's who's accessing those services. I think that's what Anthony was alluding to as well. So, you know, the figures are for general access for everybody, but we know that the highest levels of tooth decay amongst those in the more deprived areas, and the other groups I explained, you know, such as the homeless population as well. So in terms of kind of ensuring that the resources are best used in the best way, you know, we have started to set up a dental service for those experiencing homelessness in Doncaster that should hopefully be up and running in the next few weeks. But also the flexible commissioning scheme, it takes referrals from health visitors and looked after children's teams for any children who don't have an NHS dentist who are at high risk of poor oral health. So anyone identified in that way can be referred through to one of the flexible commissioning practices. So hopefully we're picking up on some of the most vulnerable in Doncaster that really, really do need to access care in a timely fashion.
Okay, thank you. Karen?
A quick question. Well, it's a couple of comments really. Access to dental care. You know, in some of our communities where there is significantly high health inequalities, and I use Stainforth as an example because when we started the Shaping Stainforth, it was brought up, you know, through conversations with residents, the access to a dentist is non-existent. There is dentists there, but there's no, you know, practicing dentists. And these are great examples of people live in them communities that they're having to travel to the nearest one, which is in Thorn, and how, you know, for some residents who can't drive, that's a massive barrier. So having a dentist within communities would be, you know, a starting point for me. So that was one thing. The other thing was, you made reference to some of the schemes that you're doing, and I know the toothbrushing activities that they're doing, the early, you know, in those settings and child mind, it's not something that's new, but actually what impact it's having, because we can see that, you know, the dental decay in those under fives is massive. Is it not something around the education with parents, because you're asking somebody else to do it and then they're not going to carry it on at home? I've had conversations where toothbrushes with the adults have been a massive issue as well. So it's not criticism, it's just comments that have been, you know, been around quite a while that these things have happened. And I know with the family hubs now, we've got the early days workers, so there is that more increased sort of opportunities to get that message out to parents by working together. But it's just you know, those toothbrushing challenges, they have been around a long time, and to what effect have they had? And I know that it's one opportunity, but yeah, it's just a comment.
Okay, Cara, did you want to reply to that, or do you want to take the other questions? Okay.
So just on that one, I did want to include oral health schemes and oral health things on top of access to dentistry. It's where the local authority responsibility or opportunity is. The number one thing that will improve dental health and oral health is fluoridation of water supplies. Doncaster water is not fluoridated. We have completed across the South Yorkshire area, because that's where the pipes run. They don't run just in Doncaster, they go across South Yorkshire and a tiny bit beyond. Completed a scheme and a survey with engineers that have concluded that there's an efficient and operable scheme that would fluoridate water supplies, including that in Doncaster, and that has been delivered now to Secretary of State for decision around that. So that would be the number one thing that would make a difference and reduce inequalities around dental health as well. Just on the supervised toothbrushing, we choose to do that as an enhancement to services again. Good evidence that in terms of inequalities, and it's expected that it's supplemental to toothbrushing as well, and will include within our school nursing and health visiting services that the techniques around proper brushing and appropriate fluoride levels too.
So I'd say the supervised toothbrushing schemes are really, really important, because they're teaching the children the basics of how to care for themselves, you know, as part of their general care, because often it's not taught at home. But I agree with you that it's really important that it's also carried on at home. So the supervised toothbrushing isn't to be done instead of brushing at home. We're promoting that also they have the teeth brushed twice a day at home. So that message does need to get through to parents and carers. I quite agree. And there have been opportunities. I'm not certain whether this has happened in Doncaster, but it's certainly in other South Yorkshire areas where oral health packs are sent home with the children, especially just prior to kind of holiday periods. So hopefully the brushing will be continuing even when they're not at school. It's a whole school approach, so that's just, you know, one part of many things that needs to happen during you know the school day in terms of oral health. It comes kind of hand in hand with healthy food policies, and there have been opportunities certainly in other South Yorkshire areas for parents to get involved in terms of finding out about oral health, attending school meetings, and especially kind of during the reception induction kind of period for children. That's a really good opportunity to kind of raise awareness around oral health generally. In terms of return on investment, the supervised toothbrushing schemes for about for every £1 spent, there's over kind of £3 return on investment. But in terms of water fluoridation, for every £1 spent, there would be over £21 return on investment in terms of reduced treatment costs. So as Rachel was saying, water fluoridation would be the key really to improving oral health for not just children but adults as well in Doncaster. And you know, I know there's been great support across South Yorkshire over the years, and we hope that that will continue. As the Department of Health and Social Care have now taken on the responsibilities for water fluoridation, decision making and public consultation. Previously it was the responsibility of the local authorities, but that recently changed last year with the Health and Care Act.
Thank you. I'm going to take the questions from Nigel first and then Sarah. So if we're going to take them both together, and then that will move on to the next item.
Thank you, Chair. Thank you very much for that really, really comprehensive report. That's really been useful. There's just a couple of queries on it. I mean, just in terms of presentation, we've highlighted here that Doncaster has some of the highest levels of tooth decay than those seen in other South Yorkshire local authority areas, and tooth decay amongst 5-year-olds in Doncaster is the highest in other South Yorkshire LA areas. So I suppose from my perspective, it's about getting the best deal for Doncaster. I understand, you know, we're South Yorkshire wide and Yorkshire Numberside, but it's about Doncaster for me. So if that's the case, looking at your 4 initiatives to strengthen and improve access and reduce inequalities, it says here that there's 24 practices providing urgent access sessions across South Yorkshire, with 1 of these in Doncaster supporting the urgent care patient pathway. So what I'd say is, if there's 24 dentists across South Yorkshire, why is there only 1 in Doncaster when we know we've got a real issue in Doncaster in terms of sort of like, you know, tooth decay, and we know it's the highest in South Yorkshire? Why has that not been broadened? And again, we know that it's really important to engage local communities, but we also know that there's been issues in terms of ICB doing that in the past. So we've got Health Watch lined up against that with South Yorkshire, and some of the determinants around that is obviously addressing the concerns raised, communication of services availability and access to services. So I suppose what I'm asking is, how does that look in terms of communication and how we're engaging with people across South Yorkshire, more importantly Doncaster? And now we've got a percentage of people that's been engaged with and what's coming back from them. Again, moving on from that, if you look at, this is sort of like page 25 on the report, but on my pages it's coming up as 142 as well. You've got an adult oral health impacts in Yorkshire number by local authority. And it's got Yorkshire number, it's got England, but basically it's saying that Barnsley, Doncaster, Rotherham and Sheffield didn't participate in the survey. And this is from like 2018. So have we not got any more updated data from that period really? Because it's, you know, in fairness, I mean, I'd have thought that that had been included, because all I've got is a list of blanks. And then moving on from that again, I suppose what concerns me is that we're in a position where we know that the ICB has got they've got financial constraints like every service in terms of obviously local authorities as well. But we know within their envelope for dentistry and dental services, we know effectively we've got some real issues in Doncaster. And we also know that we've got some real issues in our areas of concern, which are our most deprived areas. So I understand the issue that Anthony's mentioned there in terms of, well, if you take it from this pot, it's going to obviously leave a gap there, and we can put it into that if that's a priority. But what I'd argue very, very strongly in terms of the actual dentistry envelope is that Doncaster is a special case, and there needs to be some improvement in Doncaster. So we know we've got a dentistry envelope, and we know Doncaster's got some of the highest rates. So why isn't that money being moved into Doncaster to service it properly? Because some of the initiatives that's being put forward here, and again, I look forward to, look again at that presentation that were made at the end around some of the work that we're doing. And this is sort of like basic, just bear with me, I'll find it. Yeah, so this is the Oral Health Improvement Programme. That's based from the Oral Health Needs Assessment in 2018. It's a different world now, we're post-pandemic, and we know some of the people that are waiting to see a dentist in Doncaster cannot get to see dentists, so they're either paying for it privately or, in some cases, actually doing it themselves. So I suppose that there's an argument to say that Doncaster is a special case. It's one of the areas that needs that extra investment in it. And within Doncaster, we also know that there's areas, obviously, of deprivation that need special attention as well. So really, the ICB, I'd argue, needs to step up to that and actually put some money into that. Lastly, and this question, it's aimed sort of like really at the panel, is how many kids in Doncaster have we got waiting to see a dentist? How long have they been waiting, and how long will they have to wait to see a dentist? And that really is the crux of it. That's what we want to see, those figures. How many is waiting? How long have they been waiting? And how long will they have to wait? Because once we've got that figure, we can see what sort of situation we've got in Doncaster. And we should have those figures. And I think basically this Health and Wellbeing Board needs to know that at this moment in time.
Thank you, Nigel.
Shall I start? Because there's a lot in there. Thanks, Nigel. There's a lot in there, and I'll ask the team to come back, particularly on the comms and engagement, the survey elements of things. But I'll pick up around the crux of the question, which was around resourcing, recovering access, etc. I think, as the team have demonstrated, and it is complex, isn't it, is that things like access sessions, etc., are paid for within the contract from clawback of money that we haven't spent already. And as you've seen, that actually the activity rates that we set in Doncaster, I think what I heard Debbie say is that mainly they're met, aren't they? And so we don't have that clawback of activity to do much different with. That's a complexity to it, Nigel. I recognise that. It doesn't change the fact that actually, if we've got a problem of access in Doncaster, how are we using the ICB envelope to prioritise dentistry? And I think that's more than a fair point, and I think that's my job to be looking at ensuring that dentistry fights its weight, for want of a better word, about when we're looking at allocation. So we will be doing that when we're looking at allocations of any additional money or that sort of thing in over the next 12 months. So trust me when I tell you, Nigel, that's a very live conversation. Obviously, we're striking a balance here, aren't we, around immediate access issues and longer term improvements in oral health, and we have to make that balance when looking at where our resources are. So are we better saying that here's a pot of money to say here's some additional access sessions in the immediacy, or are we better putting the money into the prevention and the education elements that have been described as described in the presentation? I think it's a balance, because those longer term improvements in oral health won't be seen tomorrow, will they? They'll be seen over the next sort of 5, 10, 15 years. So that's always a balance that we've got to strike. Doesn't change the fact that we have got a problem here in Doncaster, and I think we do need to have a look about where the resource is allocated. To your final question, and the team might help me in this as well, data's been particularly poor in dental health and access. So those seem eminently reasonable questions to me. How many kids have we got waiting, and how long are they waiting? It's a notoriously difficult thing to calculate and measure. But I do take Nigel's point that we do need to improve our data and transparency around dentistry services. Debbie, do you just want to pick up around the comms and engagement, the survey elements, etc.? Nigel, I think you were asking, weren't you, around the sort of engagement with our public and
Yeah, I mean, basically, we know that we're using a number of avenues to engage with our communities around their perceptions in terms of dentistry and access, really. And I suppose what I'm trying to find out is, how is that going, using some of those other agencies to do that, and what percentage of people in Doncaster have been, I suppose, engaged in terms of putting that forward? Because from my perspective, that's really important, because we all know it's about perception, and we know that certain perceptions are wrong as well, and I get that totally. But we need to know, and we need to be reassured that people are being engaged, and that engagement and consultation is quite meaningful, and obviously people's views and perceptions are being addressed.
So we do work closely with Health Watch. So we have links in with them. They are part of our local dental network. So we have a representative on behalf of the whole of the South Yorkshire Health Watchers joining that meeting. So they are able to feed us into the information that they're hearing from the patient voice. So they're our patient voice link directly. So we can hear that. We have engaged with them quite a bit over the COVID period, where we got them all in to speak with us, to make sure they understood what the system was in dental. Because their whole working around dental has been a bit of an unknown to many people in terms of how the system works. So we were able to engage with them, make sure they were involved with our stakeholder information and have those conversations. So I've been the link for South Yorkshire, well, the whole of South Yorkshire, in terms of Health Watch. So we've brought them into our networking system so we can hear that. They're also part of our event on the 30th of November and able to come together and speak at that as well. So they've been our main linchpin really into the public voice. Obviously there's the national comms that come out from the national team, and they've been part of, the national NHS websites and things. But we are now looking to work with the ICB on looking at what comms we can do and engage better with the South Yorkshire community. Sarah's been doing a piece of work in Sheffield, on one particular aspect of the population, and we're looking at how we can then use that across South Yorkshire as well, particularly around learning disabilities. So we've got a lot more to do on that, but we have been very linked in with Healthwatch to take that forward.
So, sorry, Chair, just to press this, that's reassuring to know, and obviously there's an awful lot going off. What concerns me, though, as being a councillor in Doncaster, in Doncaster's Health and Wellbeing Board, is exactly how people in Doncaster are being engaged. So I get totally what you're saying, and it seems to me that there's some fabulous work going on, but it's Doncaster specific for me. So in terms of engagements for Doncaster, I think it's only right that this board should ask the question. In Doncaster, in our most deprived communities that are struggling to get access to dentistry, have they been engaged with? And if they haven't, when are they likely to be?
Fran? Oh,
Hi, this is an interesting conversation having, and I'm going to be interested to find out what happens at the event. Healthwatch at this point in time are working under the ICB level. Okay, I am looking at the people that are contacting us in Doncaster direct at the moment and just seeing what's naturally flowing to us. I do have the concern that because it's being looked at from the South Yorkshire Healthwatches altogether, we're not, the ICB doesn't put money into the Healthwatches working together. So we're having to pull our resources to work into the ICB, and that means that Doncaster Place is not being represented separately at that level. So at this moment in time, what I'm doing is I'm allowing the phone calls that we're getting through. We get phone calls, people saying, you know, I can't get a dentist. If we put a post out that says which people are actually taking on NHS, I can tell you that it's our most popular social media one going out there. So at the event on the 30th, we will go, our data is going to the Healthwatch that's out there. We are being represented. What I want to do then is see how that represents and comes back to just the Doncaster Place with just the information that we're getting, because that's where I feel that actually it's such a different issue in lots of different places that it's not working when the ICB are asking us as health watchers to all work together. But I can't give you any facts and data on how that's happening until after after this event on the 30th, when we're all joined together, when we're all put together to see what recommendations it comes out, and then if it fits with the data that I'm getting just at the Doncaster level, if that sort of makes sense. And I hopefully will be able to give you some information about how it looks after that.
Okay, I think I'm going to have to move us on, Nigel. Sarah, did you want to come in?
Yes, I did. Just around the dental surveys, I think you were asking about the data that we've got. So the oral health surveys are commissioned by the local authority, and there are national surveys as part of the National Dental Epidemiology Programme. So every couple of years, 5-year-olds are surveyed, and each of the local authorities in South Yorkshire have co-commissioned the survey to be taken or provided by a fieldwork team from the University of Sheffield. So every couple of years, 5-year-old school children are surveyed, but it is a very small sample. It's only around 250 school children that are surveyed. It's a random sample, so it's just a snapshot of what's happening in Doncaster. The sample size is too small to provide analysis at ward level, so it's purely done at a Doncaster level. In times gone by, we used to do what we called census surveys, where every single child had their teeth examined, so we would have a more accurate picture of what was happening within each community as well. But there hasn't been the resource for that lately to do that level of survey. In the intervening years, the year groups are chosen. So we've just had a survey done of year 6 children, and now we're on to the next 5-year-old survey. In other intervening years, they've also looked at 3-year-old children. So in 2020, the 3-year-olds were surveyed, and at Yorkshire and Humber level, 15% of 3-year-olds were found to have tooth decay, experience of tooth decay. In terms of adults, there is less data available. So I think you were mentioning the survey in 2018, which I've just found having scrolled through the pack again. So most of the local authorities across Yorkshire and Humber didn't actually take part in that survey. So none of the South Yorkshire local authorities, and just a handful of local authorities in other parts of Yorkshire and the Humber. And the reason for that is that they were unable to secure a fieldwork team that year to provide the actual fieldwork for the survey on the ground. And that also meant there was no 5-year-old survey done in 2016-17 either. So you might have noticed that there was a little gap in the data in your packs there as well. There is currently an adult dental health survey underway, a national one by the ONS, and we hope that will be reported on in the next year or so. But again, it won't provide data at kind of ward level. It's quite a high level data set. So Doncaster or Yorkshire and Humber level will be kind of the level of data.
Okay, I'm just going to bring Sarah Smith in, and then we are way over time, and then I'm going to have to summarise what we've agreed. Thank you, Sarah.
Thanks. Just really quickly, there's substantive data on ACEs, which are adverse childhood experiences, which then translate into it's seen as a precursor to dental oral health. And it doesn't mean necessarily that people are eating junk food or not brushing their teeth properly, but other elements of that stuff like domestic abuse and things. And I do think it's a really missed opportunity that we don't have this local data like to ward level. So I represent Adwick and Carcroft, which is classed as one of the more deprived wards in Doncaster. And I get so much casework, which is people, and especially young people, but everybody, not being able to access dentists. They're calling anybody and everybody dental surgeries across Doncaster, and doesn't seem like they feel like they're going to be seen kind of thing. And then obviously we're dealing with a population that have already experienced ACEs, adverse childhood experiences, and got dental decay or oral issues. And I only just learned how to floss my teeth properly about 3-4 years ago, because nobody ever showed me, and I kind of watched it on TV, and people just go like that, but apparently it's very complicated. It takes a lot of time, and that's another thing we don't really get across. So I think there's elements that we do have control over, but I do want to really emphasize the conversation here that we're talking about is that we do need that kind of data somehow, so we can understand because these health inequalities are massive, and I'll probably say the 30% of adults and however many it was of children not seeing a dentist in the last 2 years are probably more of our deprived community, or people that have suffered some issues, so it's quite can't afford to go to the dentist, and then so I just wanted to really emphasize that I think it's really important that we get that data.
Okay, thank you. I'm going to finish it there, and I'm going to try and sum up everything that people have said. So if I don't cover something, please come back. So there were a number of recommendations. I think the biggest issue is around this, not just engagement, but understanding. And I would like to see the recommendation being more than commit to further engagement, but to actually resource engagement to understand what the issue actually is. So I'm looking at Anthony and Rachel about how we do that, because it's almost like we're dealing with national data. The access data was there, I totally agree. But if we don't understand what the wealth of the problem is, then where do we start to address it? So I think that's one of the recommendations that I'm getting nods, that we really need to understand what the current situation is, picking up Nigel's points in terms of how many children cannot see a dentist. And it's quite fundamental, this, and I want to bring in what Karen said, is that we have a wealth of anecdotal information that Doncaster have done through engagement with their communities. And I don't know how that's all been brought together into this event on the 30th of November. So I'll look to Rachel and Anthony to see how we can actually make sure that happens. Because what I don't want to do on the 30th of November is reinvent the wheel. If we already know what the issues are in some of our communities, then we need the people there like Karen and the team to actually be there to actually talk about it. And I don't know how well Health Watch are linking into that, but I think that's a really important issue. Do you know what? I just find this really shocking, the information that we've been discussing. That, you know, we're talking about 2023 and we're talking about that number of children that have got tooth decay. And I think as a Health and Wellbeing Board Chair, I think that's really embarrassing. I think that it's poor, it's more than poor. And as Sarah said, it's you know, we all know what it's like when we've got toothache. It can really affect us. If that's what you're living with day in and day out, how on earth do you sit in school and concentrate? So this to me is like one of those fundamental basics that we have got to address. Cost of living didn't come out. You know, buying toothpaste, toothbrush, flossing, mouthwash or whatever costs money. And have we factored any of this into that? Because that is a barrier. And as a local authority, if we need to look at how we support families better, then we've got to start doing that. So I think that first thing is we need the data, we need the engagement, we need to understand currently. Picking up Toby's point in terms of the numbers of dentists that could take on people, Toby's sitting there with his phone or his laptop. I didn't see anything where there's a number that people can ring anymore. If that exists, that needs to be publicised, because not everybody can go onto that website, because people are digitally excluded, and we talk about that a lot. So I'd really be keen to see that. We've got to make sure that this is part of the health and wellbeing strategy. It's almost, I want to see the health and wellbeing strategy as like fundamentals, because if people haven't got good oral health, how on earth can they actually flourish, achieve what they want to? Because it's a basic. Anthony and other health colleagues, I think the clear message is that the ICB has to look at how they can reallocate the resources that I know you haven't got to look at how we can put them into oral health. But I think that's for the local authority to look at as well in terms of a prevention. Engagement, not good enough. I'm just picking up what people said. Cost of living and how we get that information. They're about the 6 recommendations that I've picked up. Is there anything that people think I haven't mentioned? Because as a board, we've been waiting a long time for this presentation, so I want to make sure that we don't just leave it and we have the presentation, because there's clearly a lot of ongoing work. Looking at people that spoke, Rachel, have we got other things that we need to...
So not other things, but just to distill some of the summary and recommendations there. I think Nidge described the oral health needs assessment being last completed in 2018 and that lots has happened since then. So one of the mechanisms could be that we refresh, renew that oral health needs assessment and use that to look at what do we currently invest in oral health council-wise, is it in the right place and do we need to do more? So that would be our lever for that bit.
Any other recommendations? Nidge, have we captured everything? It's in there. Oh, sorry, we really have got to sort this out and look at that. Picking up again Karen's point in terms of if people can't get on a bus to get to a dentist, then they're just going to ignore it. And Nigel's right, you know, people are dealing with it themselves, which they shouldn't be. In 2023, we shouldn't be doing our own extractions or coming up with ways. So if I've captured anything, I really appreciate you coming. You probably won't want to come back again due to what we've raised, but as you can see, it's an incredibly passionate issue. What I would say in terms of that survey, we don't use counsellors enough. You know, we can get messages out to residents who would perhaps never engage in any surveys. So please, when we do that survey, look at how we can get counsellors involved. I'm thinking this needs to come back in probably the March meeting, looking at Louise. You'll have had the event in November, an opportunity to look at that data, thinking about you, Anthony, in terms of funding. You'll be having those discussions ready for the next financial year. So would March be a good time to bring it back? Okay. Thank you very much. Thank you ever so much for attending. You're welcome to stay for the rest of the meeting. We do realise that, you know, this is a very constrained area and what you are able to do. And thank you for the innovation that you're looking at already, because it really is appreciated. Okay, so we're now going to move on to youth engagement, which is our lived experience. So delighted that we've got Lucy and Grace here from Shaping Stainforth. And this is your opportunity to talk about your experiences, and based on your experiences, tell us all as health and wellbeing leads what we need to be doing differently. So take the opportunity, don't be nervous, say out how it is, because that's how we prefer it at this board. Over to you. Thank you.
Thank you, everybody. I'll just put a bit of context in what Shaping Stainforth is, because I'm quite aware that not everybody will know and how long we've been around. So we are a 3-year pilot of funded by the Health Foundation. We've just had our 2-year report, so we've got a year left. And when we first started, it was before I came in, a lot of the identification of what work needed to be put in and where the funding would go came from actually residents in the community. So there was a lot of scoping done, conversations with the residents to see what they wanted. And it's all about improving mental health and well-being within the community, looking at the wider determinants of health and what affects it. So just to let you know that within that scoping, it was identified from partners and residents that they wanted to give part of the funding to give opportunities to 2 young people within that community. And it was, you know, creating 2 apprentice opportunities. And so when I come into post, it was about understanding that community and finding these 2 apprentices. And that's how we came to have Lucy and Grace. So they are local people from that community, giving them an opportunity. And I say everywhere I go that if we don't have, you know, whatever else, that we've given these 2 young people an opportunity, I think it's massive. And that forms some of the recommendations towards the end, that how can we continue to sort of develop those local people. So do you 2 want to take a start? Yeah, do you want to? So I'll just give you a bit of they've both got a bit of a personal lived experience journey, and then we've got a bit of presentation. So can they do the personal experience first, if you want to start, Lucy, and then you do yours?
So deciding to apply for this apprenticeship was not easy at first. After I left school, I went on to college at John Leggett and studied sports and coaching. I also studied public services. My dream job was to be a personal trainer in the Royal Navy or be a PE teacher, but I didn't want to leave home or go to university. Therefore, when I left college, I applied for coaching opportunities, but heard nothing back, as this was at the time of COVID. After this, I gave up all hope of gaining a career, so I got a full-time job in a coffee shop, which was good pay, but after a year of working 45 to 48 hours a week, it was draining me physically and mentally. It changed me as a person because I became very moody and always isolated myself during my home life. All this was because I was not happy with the way my life was planning out, as I gave up hope of finding the right career path for myself. However, finding this apprenticeship helped me better myself so much. Being a health and wellbeing apprentice has helped me to decide what I want to do with my life. This apprenticeship is so beneficial to me, as it can open so many opportunities for jobs, training and career routes to go down. It also is helping me improve my development, knowledge and behaviour skills. But working within Stainforth and helping the residents make the change of communities better and safer makes me proud to be part of that community. I am also a resident of Stainforth, which is a deprived area. There is little opportunity for the youth of Stainforth. It's okay going to school and learning maths and English and other subjects, but they teach you nothing about life after school, like mortgages and how to write a CV or even apply for jobs. They discuss university and things, but what if a student from a deprived area does not want to go to university, like myself? I had no idea how to apply for jobs or prepare for an interview. I knew nothing about wages or paying taxes. I was not prepared for life after school. This apprenticeship has developed me, as I now have a better grasp of life and earning money. If I can get the opportunity to make something of myself while having a background from a deprived area with very little grades, then I would like to make a difference in my community for other young people. I believe that support should be given after school to support with applications, CVs and general support of life after school, especially to those who do want to become successful. Living in a deprived area sometimes gives a firm view of what type of person you are. A person who is less privileged and do not have the same access to services as others do in a more affluent area. As a resident, I believe that this is true. However, just because a person comes from a less deprived area does not mean they should be treated differently and not have the same opportunities as everyone else. Having bad grades and a different background does not define you as a person. So where am I now? I started my apprenticeship on the 4th of October. It has been over a year since I started, and I have gained so much from it. This has been one of the best experiences I have ever had. It has brought me so much and developed me massively. I have gained skills I would have never learnt working in my previous job. I have learnt how to work within a bigger team and to value, respect and appreciate other people's opinions and ideas. It has given me the opportunity to resit my English functional skills, which I have now passed thanks to having the opportunity of an apprenticeship. I am eternally grateful for the opportunities I have had, as it has upskilled my development and has set me on the correct career path for my career choice in working in mental health. I have made such good friends from my apprenticeship, not just within my workplace, but within my college placement. I have learnt so much from being around different people, and it has given me a different look of a working environment. I have had the opportunity to work with children in my community, residents that I know, and colleagues that have supported me. My confidence has improved so much, and I am a lot more confident when it comes to presenting and being proud with what achievements I have made. It has helped my own health and well-being, as it has given me goals and achievements that working in a cafe would have never given me. I couldn't thank everyone that has made my apprenticeship happen enough. Each and everyone that I have worked with has benefited me in one way or another. This is only the beginning of my career, and I look forward to what it brings me next.
I wrote this on the 6th of February. I don't know if that, but it makes sense towards the end. Towards the end of 2021, I fell into a bad state where I thought I was going to go nowhere. I'd left school at the age of 14 due to my physical health, which caused a skin condition which caused tennis ball blisters to form all over my body. I was never offered any support, such as for my mental health and from school, so I had left school without any homeschooling and no support in place. I went weeks without moving, and I was stuck in a deep hole with myself where I'd either not eat for days or I'd overeat and try and make myself feel better. After weeks of losing myself, I began to fight with myself to build up energy and confidence to get out and make something of myself. I went to see Susan Duran after hours of telling myself I couldn't do it, to see if I could volunteer for a few nights a week. I began a week later doing the youth club on a Friday night, and this is where I became comfortable. I started doing the luncheon clubs on a Wednesday and a Thursday, and I'd love to meet people and learn a lot, not only about their generation but from my grandparents as well. A few months went by, and I slowly began doing playgroup, and this is where I knew I wanted to work with children. After volunteering for nearly a year, Kerry came to do a workshop at the centre, and after speaking to her for a while, she was explaining to me about the apprenticeship and that I would be perfect for it. I thought about it for ages because I weren't ready to leave my comfort zone, but I took the big leap of faith and just sent the application off, which I'm so happy I did. Since starting the job, I have learnt many different things and became a happier person. It has improved my mental health and is giving me something to work towards. I am grateful to be given a second chance at becoming someone. My main worry was when I left school is nobody is going to want someone without any of their GCSEs. It's now October 2023 and it's been nearly a year since I started my role. I couldn't feel better within myself. The amount of confidence I have gained is unimaginable. When I look back to where I was last year, I would never have thought I have made it this far. I am happy, not only I'm happy not only physically but mentally. My mental health has been the best it's been in years, and I will forever be grateful for the opportunities I've been given. If there's one thing I would change, though, is the amount of mental health support for people my age, because it's a tricky situation to be in. You've just left school, so you've got no access to the school nurse, and you're only a few months away from being an adult, so there isn't actually a section you fit in without being pushed around because you're too old for the children's waiting list, but then you're too young for the adults waiting list.
So that's both the girls' story. Just to add, I know you're 21, you're just 17 still, so they are really, you know, the young people of the community, and they are working. They predominantly work with the young people within Stainforth. So we've got a presentation now, and I know you've had it shared, but it just shows some of the work and the engagement that both girls have been doing within the community, and how that those young people are now feeling listened to and valued. And now it's not been an easy process, but both girls have worked really hard to get to sort of have some structure with those young people. So do you want to just do your presentation?
So Shaping Stainforth is an initiative that supports services, groups and residents in the Stainforth area. We aim to make a happier, healthier place for everyone to live, work and play. Why is engaging with young people important? To use the young people's voices to feed back to the wider system, to keep ownership of their community, to create opportunities and develop new ambitions, to create community spirit and community cohesion. So the picture in the top corner is we did our appreciative inquiry workshops with the steering group, and at the beginning we only had 8 members, I think, and they're the members that we've had from the start, and we kind of created an action plan of what changes they wanted within their community. And I think the first one was litter. So we did a litter pick with them around the youth club, and like just the faces of that difference, like even though it's nothing massive, but that little change like made them feel better about where they live.
What have we achieved so far? We've created an area on the outside of the youth club where we've planted flowers because this is what the young people wanted, because it looked awful before. The young people are now feeding thoughts and ideas into the town council meetings. We're working with voluntary community faith sector groups. For all the hard work, they were rewarded with trips and activities. The young people steering group, we've grown. We originally had 8 members when we first started, and we're now at 25, nearly 30. The picture in the top, on the very top, is the flowers we planted. We worked alongside the Smile group, which is a group of adults with additional needs, and they started and they wanted to clear out the rubbish because they just wanted to sit outside and have somewhere nice, because it was just plain, there were weeds everywhere and there was just one bench. So we worked together with the Steer group and the Smile group to create this area outside. All the flowers were donated by Stainforth for All. Then there's Ninja Warrior, which is where we took a group of secondary secondary school students to Ninja Warrior, because this were like kind of a carrot type of thing to say, this is what you get if you work with us and you engage and you put the hard work in. And then the last picture is when we went to the farm. This was in August, because every time we asked them what trip they wanted, we offered them all sorts, and it were all to do with farm animals. So we got in touch with Growing Together, where they did half a day on the farm, and then they did different activities for team building within the afternoon.
So how are we achieving this? Myself and Grace, we go into schools and we do workshops within schools to gather the voices. So the picture on the slide, we went into Ash Hill and we did I think it was a dream workshop where you gather voices. But going into schools is important because you get like young people from all communities in one place. Whereas sometimes when we do it with just Stainforth, obviously it's just Stainforth, but when we went into schools we were highlighting other health inequalities for other communities as well. We build good relationships with young people in schools, and then myself and Grace have our steer group every fortnight that we run.
The Young People's Steering Group. The steering group is used as a platform to co-produce the Stainforth Youth's Action Plan. An appreciative inquiry approach was used within the workshops. We gathered responses from schools to develop a Stainforth Youth Action Plan, and team building activities are used as a reward scheme. So for the action plan, I think we've nearly finished like the first one now, because it were all going back to the litter pick. They wanted to make the outside of where they go to the youth club look more tidier and presentable, so that's why we did the litter pick. Because all they wanted to do was have somewhere to be proud of, and that's why the flowers ended up coming around as well. But with the litter pit, they wanted to keep emptying out the rubbish and refilling the bags, because we'd finished picking up all the rubbish. And as for the team building activities, it was we had spaghetti and marshmallows, and they had to build the highest tower possible without it falling over, and all they wanted to do was genuinely eat the spaghetti. But we got there in the end, and they did build the towers. And so, as you can see, that's the top photo. And as for the bottom photo, they kept looking at us and they wanted their own lanyards, because it's like, why do you have them and we don't? So we'd got lanyards and they'd made their own, so they feel like they're now part of something, and they feel like they're really listened to and important.
So the Unity Project. The Unity Project is one of the largest regeneration and infrastructure projects, which is located on the outskirts of Stainforth. So Shaping Stainforth took 17 young people to see the new Unity development. This was part of our youth action plan, and we were supporting young people's aspirations. So when we took them to the Unity Project, there's going to be like warehouses, a new school, another doctors. So there were loads of job opportunities. So they wanted to go see it, because kind of in their mindset is by the time that's done, they'll be looking for a job. So it kind of really fitted with their aspirations. Like we had a young girl who wanted to be like a robotics engineer, and one of the warehouses is going to be run by robots. So it kind of fit in. And then we had a young girl who wanted to be a primary school teacher, and obviously there's going to be a new school, so it kind of just interlinked with what they wanted.
Forward plan for the young people. Embedding Stainforth's young people voice into the wider Doncaster system. We're currently working with the NSPCC to form a online safety toolbox, which will be shown to all the young people around Doncaster, and that is being made by the steer group. Support strategic plan for mental health. We've got a mini person, this has already been done, we've got a mini person's young town council, and instantly when we said we were doing it, they all voted for the same person as mayor. We work with Zone 5 to 19 to ensure hyperlocal support, developing young people's community questions, because as part of our roles we do AI questions, and some of them are really hard to understand because we've took them to the young people and read it to them and it's like, what does that mean? What does that mean? So Lucy's made a new set of questions that they understand better now, so we're now getting more young people's voice, and we're upskilling young people's champion.
I think that's the end of the presentation. I just wanted to add that some of the, I know from the last health and wellbeing, the experience I had when I came here before, they were discussing the mental health strategy and refreshing it and that. And I think what I took away was, I know you use the young people, the youth council and everybody to sort of, and those young advisors, youth advisors, to kind of find out and to inform that. But there are, as Grace has experienced, those local people in community, and we could have reeled off a number of people with experiences like Grace that are getting missed, and the kind of for them to be able to contribute and support, I think it's the way forward, that we're using people within our communities and young people within our communities who we know.
I think the last few weeks has really opened our eyes, as we hosted a youth club during the school holidays, and the kids absolutely love it. So Kerry, who is the improvement officer for our team, she was going round and asking the young people as to why they come to the youth club, and majority of the responses was because they get fed and they get a safe space to go. And it kind of like really opened our eyes, because like if they didn't go school and they didn't come to the youth club, like what position does that put them in? So it just goes to show that families in deprived areas really do struggle. And I think it hit me and Grace a lot harder, because like obviously it's not that like deep for us too, but obviously working within them, like we were like, what can we do to help them kids get more, kind of.
Okay, thank you ever so much. I'm going to take any questions or comments. Right, can just people put their hands up, because then I'm just going to do the questions. So I've got Sarah Smith, Nigel, Rachel, and then Phil. Okay, and are you happy to take the questions all at once if you write them down? Okay, so we'll start with Nigel.
Yeah, just a quick in. Thank you for that. That were really good presentations from both of you. Excellent. Karen, I suppose from my perspective, I mean, what's really important, and I suppose it's about being rooted in place and recognising that community, but also the heritage of that community as well, and how it came to be. So it's really interesting to see that both of you have obviously done that bit of a tour around the Unity project, and I'm sure you're aware that it used to be the site of the old Atfield Maid, you know, they were working. So I don't know if you've done this, and you probably have, but I'm just sort of like putting it on your radar. One of the things that we did in Dennerby with Heritage Doncaster was, it was almost like an intergenerational miners' tea party. So effectively what Heritage Doncaster put on is they put they got a selection of young people coming in from the high school. They met with miners, they had a tea party, the miners brought in artefacts, they discussed obviously around the heritage of the area and how important that was to recognise that you know, everything that came before. So I don't know if you've done that, but you might want to consider it. I mean, there's a really buoyant sort of like local history group there, and they've been working really hard to sort of like try and safeguard the Atfield headstocks, you know, the big headstocks. Mick Lanigan's one of them. I'm sure if you contacted Mick would be quite happy to come along and give a bit of a chat, you know what I mean? And the other thing is there's also in place a towns board. And I don't know, and I might be talking out of place, but I think it'd be really good to sort of like approach them and see if you could get maybe young person representation on that. But that's just me. All right, thank you.
Sarah Smith.
Mine's just a comment. I just wanted to say that I worked with Lucy and Grace in Stainforth, and I thought, you know, the confidence in those spaces, and I got to see firsthand how incredible the work that you're doing with your local community, especially the young people. So I just wanted to give kudos to that and say how good it was. And it was really impressive. And thanks for telling me how to get home, because I wouldn't have known which bus to get. Thank you.
Thank you, Rachel.
So I'm just looking at the 3 recommendations that have been brought to Health and Wellbeing Board today, and I've been really pleased that the board have had the opportunity to listen to, and this is part of Shaping Stainforth, isn't it, amongst a wider methodology, but one that really brings the story of this embedded locality-based, really hyper-local working with a particular community and with those people in the community. So really pleased that Health and Wellbeing Board have had the opportunity to hear that. I would like to add an extra recommendation as well to the list, if I'm allowed, which is around the use of apprentices, or around the employment of apprentices. We talked about return on investment earlier. I think that the cost of each apprentice, we get so much in terms of return on investment. They will have conversations with young people that through our more statutory and stuffy approaches, we just won't get that same value out of. And sat behind Lucy and Grace today, we've got 2 of our other 3 degree apprentices and a graduate as well. And it's a real methodology for us in public health, and it's a health in all policies type approach. I don't mind if they choose careers elsewhere, but please take your experience of being a public health apprentice into whatever career you end up with. And I would say to other areas, there's real benefit and real opportunity around that apprentice model.
Thank you. Phil?
Yeah, it was a brilliant presentation and really inspiring. I was a bit focused on the recommendations too. So I suppose my question would be, because I think it's easy for us to nod about recommendations, but they're actually quite challenging recommendations, these are. So my question was going to be for people to say, what does good look like for these 3 recommendations, so you can really make sure you leave the room with the right commitment from people here?
Colleagues, anybody like to?
Sorry, can I just, like everybody else, I thought it was absolutely fantastic. Thank you so much. I helped to run the mental health organisation here, so I guess my reading of invest in hyper-local schemes is that I'd want us to come and spend some time understanding with you what are the gaps we're creating, because several £1 million has been invested over the last 18 months in trying to eliminate a mental health tradition of creating gaps between services. So we're clearly not getting it right. That's not. So my response to Phil's challenge would be, let's come and spend some time and understand what that gap is. Still a commitment to deliver on it, but let's understand how we reshape what we've got at the moment to meet the needs that the 3 of you have described. Thanks.
Okay, Lee, not want to put you on the spot, but I was going to add another recommendation that, yes, the point Karen mentioned in terms of the young advisors we had at the last meeting, but that we actually link in with local young people. But be interested in your views on the first recommendation about really listening to the voice of young people to support strength-based changes.
Absolutely. I mean, just to point out that the young people that engaged on the mental health strategy were predominantly from our forums. However, they acted as a conduit into schools, so it wasn't just their voice that we heard. They acted as a facilitator for lots of others. But clearly, there's still more we can do to reach into communities. And just on that point, we have invited Karen and the team to come to the next mental health strategy group to talk to us about that and how do we better connect the work that we do there, including the provision that we provide in communities around that. In terms of the listening to the voice, I mean, I think it's brilliant. I think it's great, the work that you've done, the fact that you've got town council, the fact that you're providing us with a forum to be able to come and hear your voice. I'd, such as Toby said, I'd also like to come and have a conversation with you and take the learning about what you've done so well in Stainforth into other areas. Think about the other regenerative neighbourhoods that we've got. And actually, yeah, so if we could do that, that would be great.
Thank you. So I'm going to do the recommendations, if that's okay. So obviously, I think it's a bit like when we've had other people come along. What tends to happen is that there are lots of next steps, because this is just the start. So you've obviously got Toby, Lee and others that will be coming along. You're obviously going to go to the mental health group as well. And then obviously then we can perhaps agree the recommendations, because until we understand then invest in hyperlocal mental health services. I think we need to understand what the issues are better. And then obviously linking in with other work that we're doing across Doncaster. But the mental health group will be the place to be able to bring that together. Happy to add in the apprentices. I think you're absolutely right. You know, it is brilliant that you're here today. And as a council, we need to do an awful lot more, and I would encourage others to have more apprentices. And apprentices from the local communities working on local projects is something that we should all be supporting. And then the other recommendation is how can you link in with the other young advisors to make sure that we hear that your local experience, and I think that's something we'll be asking to see when the mental health strategy comes back for young people in terms of how you've been linked in. So they're the recommendations. I hope it's not been too daunting. Yeah, okay.
Sorry, I'll just add that I am accountable to external evaluators, so I will share my year 2 report with everybody. But also one of the recommendations from that is how do we change and support changing systems. So I want to thank you for having that opportunity, because what we've done here today is actually meeting that recommendation as well. So yeah, thank you.
Okay, so just on behalf of the board, I'd like to thank you all for attending. Sorry, Karen, but to focus on Lucy and Grace, your presentations were absolutely fantastic. To hear your lived experience must have been incredibly daunting to sit here and do, but please believe that what you've told us today is going to make a difference. It is going to influence the way that we work, and we'd all really like to thank you for giving up your time. What I always say is that we don't want just to have the presentation now. I'll work with Louise and see when we get an update, and you might want to come back. We've got those recommendations. We'd like to hear from you that they've been achieved. So perhaps again coming back to the March meeting, but I'll ask Louise to arrange that. But on behalf of the board, I would like to thank you both for coming. You've been absolutely fantastic, and we really appreciate it. Thank you. You're welcome to stay, or you can go, but it's entirely up to you. It might be useful if you can stay for the next one, because actually, if you've got time, that would be great. So we are now going to move on to item 9, and I'm hoping Rachel is going to give me some time back, because if not, we're going to be in here a long time. Fairness and Wellbeing Commission recommendations. This is something lots of us have been involved in for a long time, so I'm going to hand over to Rachel, who is going to give us an update on the progress that our Fairness and Wellbeing Commission has been making. Thank you, Rachel.
And I'm going to make some real selective use of the 21 slides that are here. The slides didn't go out with the pack, but we will send them around afterwards. The purpose of today's session is not to pick through each of the findings and recommendations, but again to describe in the health and wellbeing format the process that the Fairness and Wellbeing Commission has gone through and the methodologies used. So it's to give you that assurance of the Fairness and Wellbeing Commission process. I know some of you will have heard some or parts of this presentation, and there are members of the Commission in the room as well. As I'm going through, though, I will put up on the screen the recommendations as they are in the current form, and there is an additional session, a workshop session for members of the Health and Wellbeing Board that's in plan that should happen before the end of this month, that you'll all get an invitation to, and that'll be an online session, so that's your chance to really dig into the products. So again, if you've seen of this, the purpose and the approach of Fairness and Wellbeing Commission, so we all got together as a commission at the start of this year, and we've had a number of sessions that have really taken a chance to step back and look deeper at what's our longer term challenges and view around fairness and wellbeing for Doncaster society. We did a number of things, and I'm expecting this is bringing flashbacks to some people in the room as well. So we had a real in-depth explore of the data. We used evidence and insight that we already had, and we had experts come to talk to us. We also had some academics as part of our commission who came and provided us with the evidence of what works and a reflection of how that does or might work in Doncaster. So that was our approach. The task of the Commission is to produce a public report, and also will have a role and responsibility around lobbying and advocating as well. That's not me, that's Dame Rosie Winterton, who was our chair and who has taken us through the process, and you can see on there the list of Commission members, and we also had experts join each of our sessions too. The principles and values that we worked on were set at the very first meeting. We knew that resident voice was really important, but we didn't want to bring people to the front of the room to tell us about what would be some of the worst moments of their lives. So we used a real mixed methods approach, which I will take you through. And you can see examples there. So we did a call for evidence that was based on resident voice that had already been collated. We synthesised that existing resident engagement. We completed a number of public engagement exercises that included face-to-face conversations, and we had an online survey as well. There were resident workshops that went out into various places in our communities, and forums and opportunities to feed into. And from that, what we developed was a set of personas, so real life stories of people living in Doncaster, and we use those as the lens or the understanding of experiences that people were having. I've mentioned the expert panels, so we approach people to come to talk to us, either from their role as professionals or people with responsibilities for areas, or with the ethnographic type research that they do. So there's a photograph project here that talked about children's aspirations. We heard from that project as well. The data walks was a refresh and renew of all the data that was available to us, and you can see on the bottom corner there about commissioners went around the room and told them what they were shocked about, what they were surprised about on that data walk. The journey in numbers, the 600 post-its plus recorded. Probably most of you have been in workshop sessions like that, but it's been a real process of spending the time, digging into the information that's available, talking as a group, listening and hearing, and then coming back and reforming as a group to develop those recommendations. There's also chances for formal evidence submissions as well that we received, so really went into that pot of information that we've got. This is what you're going to be most interested in, the findings, and as we move through the recommendations, and it's on the screen as a bit of a teaser for now, because that separate session, the workshop session, will be where we get a chance to dig into them now that I've told you about the methodology that we've used. I'm expecting most members of the Health and Wellbeing Board will tell me that there's no surprises in these findings, and no surprises in the recommendations as well. But what I will ask partners, Team Doncaster partners and others to do is to challenge themselves about why are we okay or happy that this is still a problem, and what can we do together to start to really tackle some of these longer lived and longer experienced issues that the group have found. So I am flicking backwards and forwards. Some of you will have seen those, or some of them will have had a chance already to comment on them. The commissioners themselves have been tasked with going out and socialising the recommendations, and that is part of the process that we're in now. And anybody at Team Doncaster Summit next week will also have a closer look. So I am skipping and moving through these, will be in your packs, and you will be invited to the workshop session as well. But yeah, just generally recommendations under a series of areas. And the other part, and my last couple of slides that I'll show you, is around acknowledging the gaps. So the process that we had, we've not been able to speak to every single person here, every single experience in Doncaster, and we need to acknowledge that, and we need to accept that there will be other things that we need to do outside of the recommendations as well, and just that complex landscape that we live in. We're still happy to hear where those gaps feel and what the actions might be around those. So timeline and where we are now, we're inside this red box. We're just about in the middle of it. This is the Health and Wellbeing Board update and the socialising recommendation stage that I've mentioned, and also that Team Doncaster Summit will happen too. The workshop for Health and Wellbeing Board members will happen before the end of November. We're just getting the date and checking availability for that. And then the next tasks around exec board presentation and the presentation of the final report. So we'll have, again, a revisit to Health and Wellbeing Board in our January session as well, once we've gone through the next steps of process. And then the asks for Health and Wellbeing Board today is to take note of the progress, so that methodology and approach that I've described, as well, provide any suggestions or opportunities. And I would say contact me directly about those groups rather than open it up to questions, Chair, if that's okay, to save some of the time. So I'm happy to receive any ideas of any of the forums. Rosie has offered to speak as well if you've got some particular forums where that would be useful. And then that last one, which is to attend that informal session for Health and Wellbeing Board members to really look in and dig into the recommendations and the products. And every session that we did, there's a summary online for them, and there is a chance for you to either respond either informally as individual or on behalf of your organisations or any groups, and that response can go to the Fairness and Wellbeing Commission email that's there. So we'll send all of these around so you can look closer. Thanks, Chair.
Thank you very much. Any comments? People happy with the recommendations? Happy to commit to the session? Sorry, Nigel. Thank you. Nobody got any comment? Thank you very much. Thank you for that. And I think we do have to recognise that the Commission has been a fantastic piece of work, and you know it was Rupert's idea that we set that up. So I think we were always really wanting to make sure that what the outcome is something that he would have been proud of. So yeah. Okay, so we're going to move on to the next important item agenda, which is a smoke-free generation. And Rachel, it's you again. Thank you.
And it's me again with a same but slightly different hat. So this is around the Prime Minister's recent announcement around potential legislation for a smoke-free generation. It also includes additional investment in local authorities, stop smoking services and in trade-in standards. But what I'm going to focus today on is the two proposed areas of legislation. And what I want to get from Health and Wellbeing Board today is that endorsement for the proposed legislation, and as part of that a couple of actions. One of them will be a response to the national consultation that's out around vaping and changes to age of sale. The other one is around supporting and encouraging schools on the response to the vaping consultation. And then the last one will be writing to our Doncaster MPs who will have the vote around the legislation. But before I try to get your support for that, there's a couple of bits that I just wanted to cover. So the legislation itself is described in the papers, and there's two areas of it. One is around age of sale, and this is not about making smoking illegal for anybody. It's making the process of selling cigarettes to age groups, which will change year on year over a series of years. That is where the legislation lands. So it's not about making smoking as an act or a practice illegal. That's where it is. And then there's another consultation out around marketing of vapes, and this is intended to reduce the attractiveness of vapes. So that will look at how we might have a plain packaging or restrict the marketing of vapes, or the attractiveness in terms of flavours and colours used in marketing of vapes as well. You would expect me to tell you about the impact of smoking, and I will in summary. There have been decades of evidence and research about the impact of smoking on health and well-being, the impact on wider costs and local economy. That's all in the information that I've given you. But directors of public health, consultants in public health quite like often to use this phrase to summarise it, in that tobacco is the only legal product that when used as intended will kill you. So I think that that gives us our kind of status of where we stand. Smoking is still an issue in Doncaster, and those rates have been static until quite recently. So around 18% of people smoking, despite our smoking cessation services helping people quit, which tells us that there's probably more people starting at the same rate as people quitting as well. Our pupil lifestyle survey tells us that a number of young people live in households where people smoke, and as you would expect as well, there's a real inequalities story around that. Around 2/3 of people who smoke start before they turn the age of 18, and they try to quit multiple times. And we need to reframe the way that we're looking at smoking as not a lifestyle choice, but as an addiction that grips people that they struggle to stop doing. So in that case, I'm asking the group, asking the Health and Wellbeing Board to formally support the proposed legislation made by the Prime Minister and included in the King's speech earlier this week, and for us to do those three things. One, which is to respond to the consultation, our tobacco control group can do that, to support schools in responding to the consultation on vaping, and then the last one, to write to our Doncaster MPs with that Doncaster context and with our recommendation to support. Thank you.
Thank you very much, Rachel. Any comments, questions? People are nodding. Everybody happy to support the recommendations? Lovely, thank you very much. So we will move on to our last item, which is item 11, and welcome Mandy, Marius and Whitley. Lovely to have you with us, and I hope you found it not too bad to sit through the whole meeting. But you're going to talk to us about health inequalities and a focus on the Gypsy Roma traveller community. Thank you.
Okay, so good morning, everybody. I'd just like to introduce Marius and Whit, who are two community link workers working with a focus on the Gypsy Roma traveller community, who are going to lead most of the session today. But just in terms of aims of what we want to cover today, we want to sort of bring to your attention the inequalities facing our Gypsy Roma traveller communities and the impact of those inequalities on their health and well-being. And they ask of the Health and Wellbeing Board I haven't worded this very well, to get behind the Be Kind campaign for our Gypsy Roma traveller communities and to support a more integrated approach to improving the health and well-being of these communities. So if I just pass over to you, Marius.
Good morning. Thank you very much for having me here. Madam Chair, Mandy, esteemed supporters. Today I might start presenting you something that might look a little bit different, or sometimes you hear the story of health inequalities that are happening between different groups. But I wanted to start with a positive note. Today, I put a search in the bunch of documents that was for this meeting, and I found out that the word Roma was repeated 61 times. I think this is an achievement. It's a political achievement that we succeeded to climb on the public agenda, and we will discuss about the health inequalities between different groups. Sometimes our discussion might be in a positive terms, sometimes might be contending, sometimes might have notes of criticism. But today, I wanted to highlight something that it's already known, but also I want to bring to your attention some groundbreaking research done by different bodies, from academia, from Race and Health Observatory, but also some anecdotal data and things that are emulating from what it's called meta-analysis of the existing studies and things. So, as you might know, here in Doncaster, we do have a significant number of Gypsy Roma and travelers. Those data are at the level of guesstimation, but what is for sure is that those people remain quite visible, and we see them in our everyday life. In terms of health inequalities, when we are talking differences between majority population and Gypsy Roma and travelers' health inequalities, they are somehow manifesting at the level of access. And we know that a longitudinal study show quite huge difference in GP registration when we talk about Gypsy Roma and travelers. We do have lived experience, and we do have anecdotal data that still the experience of Gypsy Roma and travelers in the health care provider settings, it's still negative, or however is different than the majority population. And not the last, it's sometimes the peak of the iceberg, but if you are a gypsy or traveler, you live on average 25 years less than majority population. If you are a gypsy Roma or traveler at the age of 60, your health conditions might be comparable with an 80 years old British citizen or dweller. If you are gypsy Roma or traveler, you are over 12 times more likely to suffer from one or more physical condition, and you will see later on that psychical conditions are also quite elevated. But all these inequalities, sometimes they are starting from perinatal phases. It starts with the day 0, and it's going all over the life. So a study that somehow it's a result of what we are calling meta-analysis. It's revealing that being gypsy or traveler mother. Oh.
Do you want me to do that for you?
Yeah, sorry. I'm not good with technology. It's revealing that there is a propensity of 20 times more likely to experience death at birth. We know from the data of Race and Health Observatory that other minorities, as Black minority, the propensity is 4 times to 5 times more. But we do have this data with 20 times more, with a basis starting in 2008 with a very serious research institute from Cambridge. It was repeated or very close to this data in 2013. And this year, a study made by Gypsy Roma Friends and Family, FFT, organization somehow revealed the same. So yes, we do have health inequalities at the very beginning of our life. They do continue during the childhood, and mental health. It's also a condition that it has striking outcomes. So if you are a GRT, you have 3 times propensity to be anxious. If you are a GRT, you have twice likely to suffer from a depression. And if you are an Irish traveler, man, you have propensity 7 times more to die by suicide. So in another note, it's bringing us the relationship of hate crimes and discrimination. And here it's coming in my mind, a study done by Professor Margaret Greenfield, a longitudinal study trying to correlate the effects of hate crimes and Gypsy, Roma, and traveler communities. And the title of the article, for the ones that are making notes, it's Hate as Regular as Rain. And the correlation, it's quite high. I'm cautious of time, and I will try to speed up with my broken English. Of course, that we have some challenges, as I mentioned at the beginning, and they might be hate crime, marginalization, discrimination, sometimes cultural beliefs. It was mentioned the level of literacy and access to gadgets and other type of exclusion, including digital exclusion, poverty, access to transport, and unconscious bias and staff attitude from the services. In 2003, one of the biggest survey with the biggest number of Gypsy, Roma, and Traveler participants, it's revealing us. Can we do next, please? It's revealing us that 62 Gypsy and Travelers people reported having a racial abuse and experience other types of hate. 47 of the Roma population have reported being racially assaulted, and this it's going on. So we do have data from 2023 done by a research institute from Manchester University, and the data it's sample and is valid at the national level. But those are just the tip of the iceberg. We have to look to understand how and from where all these health inequalities are coming through the wider lens of housing and correlation with health inequalities, socioeconomic deprivation also, and here we have more than half of Gypsy, Roma, and Travelers people having no educational qualification. By the way, last month, on 31 of October, the Office of National Statistics ran a secondary data analysis, and they revealed that in the UK, we do have over 100,000 Roma registered in the UK. I will share with you if you are interested on the findings. 85% of Gypsy and Travelers men, they are in precarious employment as compared with 19% of Brits. Gypsy community accounts as a comparison with 6% in the prison population, and as we know, it's very low percentage at the overall population. I mentioned already that among the Gypsy, Roma, and Travelers peoples, some differences might start at birth, but they might continue in a school. A report presented at All Party Parliamentarian Group last year revealed that 86% of children from Gypsy, Roma community reported as being suffering bullying and having challenges in the school system. I think this is a quite high percentage, and we have to continue this conversation, because I'm pretty sure that this might have a high impact on their emotional well-being and, why not, mental health. More than 50% of GRT students presented non-attendance, so lower attendance. It might be correlated with the bullying and what is happening there in the school. And not the last, it's low attainment of other groups. I will stop here, and I will invite our colleague Whitley Mary Smith to share with you a part of lived experience, and it's not a story, but it's something that would be combined of a day of work and how do we feel, having in mind that we belong to this minority, and sometimes we might be portrayed as being subjective. Thank you very much.
Hi everyone, can you hear me? Yeah. So, morning everybody. So yeah, Marius is right. So I am gonna speak in the context of a story. The story, it doesn't start off positive.
but there is a positive outcome at the end. So the story that I'm going to tell you about is about a young woman that I'm actually very proud of, somebody that I've worked with. She's an Irish travelling lady. She's 28, so she's a year younger than me. I met this young lady when we were small, so she was my friend. I attended a wedding when she was 17. After her wedding, she moved to Darlington, and then she moved to London. So I actually didn't lay eyes on her for another 8 years. That's quite popular in our community. You know, you do tend to move where the husband's family is. So at the start of this lady's marriage, for the first 2 years, the marriage was okay. Then the marriage tended to break down. So after her first child, she suffered a lot of domestic abuse, emotional abuse, mental abuse. You know, let me give you an example. So not being able to speak to me or any of her friends. The only people that she could speak to are members of her family. She wasn't allowed social media. He let a little girl go to school, but when a little boy was born and when it was time for him to go to nursery, he wouldn't allow him to go. He were very, very controlling. So she first lived in Darlington. You know, when you're young and you're in a marriage, I think you just try and stick it out. So she moved to London for what he called, you know, a fresh start. That didn't happen. The only company that she had was his sister, as he moved on to his sister's yard. So for anybody that doesn't know, a yard is basically a big plot of ground. So you'll have a mobile home on there, a chalet or a small bungalow, and then you'll have like a shed, which is a kitchen area, a washing area, washer. To be fair, it doesn't sound like much, but they are quite grand places. So she lived on there, and the physical abuse was getting too much. When a little girl would go into school, you know, I think the teachers could see the signs in the little girl. She wasn't speaking very much. She was very jittery. The little girl wasn't attending school all the time because if her mother had a black eye, she obviously didn't want to take her into school. So one day she made the conscious choice to come back down to Doncaster. This is her hometown. This is where all her family are, apart from one member of her family that lives in Ireland. So she came back and she had to live on her brother's yard. So on her brother's yard, she had a small mobile home. So it was winter time. So that means she's using a lot of gas bottles, which is very costly. She's got no running water. She hasn't got her own shower, her own washing machine. She's got 2 children. So she's constantly having to ask her brother for stuff, which is quite, you know, it's quite demeaning. You know, she doesn't feel great. So I went to a young girl's funeral. A young woman in our community who was 16 took her own life. And this is the first time that I actually seen the lady again. So it was a very big funeral. I went to the wake at Clay Lane site, and then we had the funeral the next day. And I spoke to her and I said, "Are you all right?" She said, "You know, yeah, we're." And she actually reached out to me on Messenger on social media because I'd done a women's group in a church about 6 months previously. So she was aware of what my job is. And initially, what she actually wanted help with was housing. So, you know, she wanted a home for her kids and a bit of stability. She was still in contact with her husband, but he wasn't coming to visit, so it was only phone calls. This woman had been to see a doctor, a GP. Her hair was falling out due to a mental state. She had psoriasis, so that would flare up when, you know, she got into a bad way. When she went to see the GP did provide her sertraline and also another tablet that said, "This will help your anxiety, but your hair will still fall out." The lady didn't feel good after that interaction. Obviously, she's been through a lot already, so her sister-in-law had to go to the appointment with her in the first place. It wasn't a great experience. So when I met Katie, initially I put her in touch with St. Ledger Homes and Creative Support, helped her out, you know, write a few letters and stuff and emails and really, really describe the conditions that she was living in. Katie can read and write, but at a very small level. So her spelling isn't great. It might not make sense to other people. So I helped her out with that. And then we got talking and I said, you know, what about the kids going to school? You know, they need some stability. It'll give you a break. It'll give you a chance to, you know, get stuff done, go and get stuff from when you get a house. So she didn't have a vehicle at the time. So she enrolled the children in a Catholic school where she could walk to. Again, you know, conditions wasn't great with the weather and stuff, but she made it there. And we actually spoke to the teacher on a 3-way conversation.
and would describe, you know, what the kids have been through, but not in depth, because Katie was so worried about the children being took off her that she didn't seek any domestic abuse help. All she really wanted help with was the housing. She just wanted to put the teachers right, so they knew if the kids were saying stuff, or if a young boy were quite, I mean, boys are boisterous anyway, but he was quite not well behaved. So, you know, she wanted to put that into context for the teachers, not to give him a break, but just to give a bit of information behind that. So eventually, the kids were both in school. Katie managed to get her own home after 5 months, so she was at the top band. The kids have now got a stable home. They're in school. She did move GP surgeries after that interaction, so she's now at one near Bawtry. A little girl is now getting a brace, so she does have access to dental care. Because we had the talk with the school, there's an app. So when, you know, if they've got to go on a school trip and stuff like that, because Katie's not great at reading and writing, she can actually talk into a phone, and it spells it out for her, which is great. The kids do have minimal contact with the husband, but they have still got some contact with him. And the reason why I'm telling this story is because it's a big thing for Katie to come home. You know, sometimes in our community, it can be a shame. You know, people can look down on you. Divorce is a taboo subject. I mean, it is, people do it now, but at the very, you know, it's really got to be a good reason for them to do that. And at the moment, she's not obviously exactly where she needs to be, but because we've given her the support and tools, she now feels empowered to do stuff herself. You know, I've seen her home. She's got a beautiful home. Her kids are doing really, really well at school. They've got access to healthcare. She's back near her family. You know, she doesn't have that many friends, because I think that what she's been through, she's got trust issues. That's why she's not here telling the story, and why I'm not saying her last name. But what this goes to show is, if we do give people the right support and tools, like, for example, how the school have helped to set up the app, you know, people can trust us. You know, we are here to help. We're not here to judge. I am from the community myself. I always say I'm like Hovis, I'm best of both. My mum isn't. That's probably why I'm sat in this chair. And my dad is. So I've got a really good perspective, and that's why I'm so passionate at helping people, because there was a time where I could have gone down a different path, and thank God I chose the other one. And now Katie is at living proof. And, you know, in our community, it's all about the talk. Everybody talks to everybody. So her doing what she's done will also set an example for other people, and she will also be able to speak to other people about the health system. And I want you to speak to the right people, or you articulate yourself properly. There is a help out there. So, you know, the story did start off as a bit negative, and it is a bit sad and deep, but it did end on a positive note. And her children, who are our next generation in this world, will now have a chance. No, they didn't have the best start, but her little girl is nearly 11 and her little boy is 8. So they have still got a very good chance in this world to be the people that they want to be, and be good people and be advocates just like myself and Marius, you know, to make these changes. I'm really aware that I probably spoke for more than 5 minutes, and I'm really sorry. That always tends to be the case, but I do appreciate you listening to my story, and I hope that, you know, if you're in your everyday work or you come across a member of our community, that this does change your perspective a little bit.
Thank you, Whit and Marius. We had the central locality workshop yesterday, and Whit spoke there as well. And actually, there were 100 people there from health and care and everybody else, and actually you could really see some light bulbs going on in the room in terms of some unconscious bias and attitude, and we could see that, because what we know is that people from Gypsy Roma Travel, but inclusion health groups in general, and probably our Core 20, it just takes one bad experience when they try to access a service and they won't go back, and that then leads to the significant poor outcomes that we see. Just wanted to just go back one slide and almost to, it's not all negative in any way, shape or form about these communities, and you know, what should we be celebrating? And I think sometimes when the cultures are so different, we almost think, well, we need to be influencing the culture, and we need to be thinking about, you know, what do they need to be doing differently in order to be able to have improved their outcomes, etc. People from a Gypsy Roma traveller community are staunchly proud of their distinct identity. And of course, they've got no intentions of changing their culture and doing things differently. So we need to be really thinking about how can we make sure that we understand that culture. And I would say the understanding of that at the moment is almost zip, hardly there at all. They're really family orientated, and that includes extended family, and they do take care of their older people. They observe really strict hygiene rules. They've got an amazingly strong work ethic. They're entrepreneurial, they're generous, and they give to charities. They support people that need that help, and they've got a strong faith. So much of that community is just amazing, but we don't see it. And we don't take the time to understand it. And if we understood it better, and because they don't trust us, absolutely don't trust any of us at the moment, and possibly are never going to trust us, but actually we need to invest some more time. And I think for me, what we've observed with Marius and Whit is that building those trusted relationships and starting to make those different connections with the communities. But I just wanted to, I'm going the wrong way, apologies. So I guess just in summary then, the GRT communities experience some of the worst inequalities, resulting in significant issues with their mental health and physical health, hate, crime and marginalisation, and we can't overemphasise this. That's the biggest challenge that this community face in terms of being able to access any health and care services. The discrimination is affecting their children right from their very early days, and that's going to impact on their adult lives. So there's a bit of a sense for me, so the Minorities Partnership Board, there was a few things happened last week. Minorities Partnership Board, we were talking about ethnic minority groups generally, and just the invisibility of some of these groups to many of our services. And then there was somebody there who actually said, well, that's not quite true, because enforcement services know exactly where these communities are. So it's really made us, I think we need to look at this with a slightly different lens, which is about health and a well-being lens, and how might we work in partnership with enforcement services and wider partners in order to be able to build more trust and relationships, but also to better understand the challenges and think about how might we do it together. And I think Whit's example gives us a real good opportunity to look at, well, it was the school, it was health, it was, it's not just one part of the system. Would you like to say one thing? Would you? Go on then.
Just lastly, everybody, as well, what I would like to say is, obviously we're all here to do with health and well-being. Our culture won't change, but we can all be culturally aware. And, me and Marius do offer short presentations, short insights into healthcare services where we talk about our culture. It's not too in-depth, it's quite a humane, and we are willing to offer that, because if we can adapt and, be culturally aware, then we can have the right conversations, and our health services have then got the confidence to have the right conversations. And if they think something is up, then they can challenge, they can challenge a person that they're speaking to, and they might be able to get somewhere. I mean, mental health's a massive one because of the pressure that sometimes we are put under. Men to earn a lot of money, women to be this certain woman, to be, the cleanest person, look the best, and these crazy outcomes, and be the best mother that they can possibly be. They do get a lot of pressure, so it's different for men and women. But, as Tyson Fury does a lot to do with mental health, because he really suffers. I mean, his dad's really old-fashioned, so I can imagine the way he grew up, probably similar to my dad. It wasn't really spoken to. It was violent. That's the way you were disciplined. I'm guessing he was the same. So just to be culturally aware will help mentally more than physically. So I know it's a lot to do with access to healthcare, but if we can help people mentally, it does all start up here. Thanks.
So very last slide. So I guess it's just recognising the different partners around the table, and how do we make as Rupert would always say, how do we make the invisible visible? And when we're thinking about resource allocation, and focusing on our communities that are experiencing the worst health outcomes, and, this is one group the inclusion health groups. There's many more. And we've also got the levels of, you know, the 40% of Doncaster living in the most deprived 20%. So we need to keep that in our heads all of the time, I think, when we're looking at resource allocation. But housing is massive, and obviously we've got, I think, Ledger here. There's all of the health, how we get upstream, so early intervention, so that at the moment, you know, not everybody is registered with a GP. So how do we start to address some of that sort of stuff? Local authority team, Doncaster, the voluntary sector, how do we get some peer support into this world? I was listening to the Stainford thing and thinking, well, you know, brilliant. That was brilliant, by the way, ladies. But, you know, how can we take the way of working there and adapt it in a way that might suit the culture of this group? Education is massive, and the head teachers, and we've got examples in Doncaster where there are some head teachers that are just brilliant. But I think that it's always the case with this, that there are small groups everywhere that are doing brilliant work, but it's definitely not consistent. Employment, you know, it's as a massive thing, and you know, Whit and Marius are both here. They have moved into employment and they have got jobs. They're not necessarily following the typical plan. Police, you know, we did a presentation to the youth offending, or Whit did a presentation that was what brought it, highlighted they know nothing, I think, but they were really pleased that we were there and really happy that we'd done it. And then, so I guess I'll shut up now. There is a big issue about workforce and unconscious bias. That's something that keeps coming up. So yes, I guess it's do the Health and Wellbeing Board support a more integrated approach to improving the health of our Gypsy Roma traveller communities?
Okay, thank you ever so much for that, really insightful. So I'm just very aware of the time because we have gone a bit over, and I'm just looking to, I know colleagues have to be out of here by 12 o'clock, that's the problem because they've got other meetings, but I'm just keen to hear one thing that our colleagues in the room are going to do, because I don't get a sense of where this is happening already. That didn't come out of the presentation about, is this happening? There's reference in your, to say that things are happening, but it's not consistent or joined up.
It's definitely not happening in a joined up way. So there are little pockets of people connecting. There's some work going on with St Ledger. There's some work going on in other places, but it is definitely not an integrated, pulled together approach.
But did you want to come in?
I think you're inviting one thing, so I was going to offer you our one thing, if that's helpful. So our one thing's in two parts. So as you guys know, by 2027, we've said we'll be in a place where the judgment of the local community is that we are meaningfully accessible as an Ardèche service. We can debate what that means, but ultimately it's not for me to judge, if that makes sense. So we'll work with you on that. I think the one thing is your point about cultural competence. So during the first 6 months of next year, we will work with you on our employees' insight and appreciation of the various communities that we're talking about who live locally. I think that's the most useful first step we can make with you. Cheers.
If all organisations were agreeing.
Yeah, thank you very much for the presentation. It's interesting, and it becomes slightly personal in that my wife is a mental health nurse, and the educational programme she pursued was she did a master's programme in equality and diversity with Bradford University, and as you do in families, what I used to do was proofread all her assignments and everything, and because that's helpful in trying to pass. One of the assignments I do remember is an assignment she did on the Gypsy Roma community and the inequalities that were being experienced, and she works in Sheffield. And a lot of what you've talked about today are the same things she talked about in an assignment I read probably 10 years ago. So I do think that there is a moral as well as a health and wellbeing imperative to try and do what we can in senior positions to make it better. So I'm very happy to to sit down with Mandy and and other colleagues and work out what we can do to try to push things on as much as we can.
Thank you very much, Richard. And what I would ask is that everybody has that conversation with Mandy, Whitley and Marius as well, that we have a collective... I've got a meeting on Choose Kindness at 12.
A mini one, so just reflecting, there's a couple of nameplates at the front on this table and areas that aren't represented, and without naming them, there's perhaps other areas or other Team Doncaster partners as well that either hear or need to see the same as what we've seen as a partial health and wellbeing board today. Thank you.
Okay, so what I would ask is that as a Health and Wellbeing Board, Louise, if we can contact the people that aren't here and we can have that conversation with colleagues that are, to work with you to come up with recommendations. And as you've heard, perhaps let us know at the March meeting what's happened, what's changed, the difference it's made. Choose Kindness, you mentioned, we've changed the name. I'll have a separate conversation because we've already got plans starting from next Monday and you need to be included in those. Okay. So it has been a fantastic meeting as always, so many different discussions. Thank you so much for your contributions, particularly our guests that have come along. And please go away thinking we have listened, we will make the changes, but with you rather than not involving you. Our next meeting is the 11th of January. So as I always do at this meeting, I will be the first to wish you season's greetings, Merry Christmas, and I look forward to seeing and a Happy New Year. Thank you very much.